Appreciate everyone's attendance. Okay, we're good to go. Okay, good morning again, and welcome those folks out there participating remotely. Welcome to beautiful Riverton. Day 2 of the Revenue Committee, and a couple of housekeeping things, Mr. Co-Chair, and appreciate your good work yesterday chairing the committee. A couple of things. I think when we adopted our rules yesterday as a committee, I got a little ahead of my skis. I was looking at the proposed management council policy, got home last night, and I just kind of had the spidey senses tingling a little bit and did some more work. It was about 6:30 at night. I think management council, through an interesting vote, close vote, does allow remote participation by members of committees during the interim. So, and our committee rules are contrary to that. I propose that. So I would open that up after we take roll. That's one thing we're going to have to do. So we got to clean that up. The next thing is really this whole mic issue. And so there's really 2 sets of mics we've learned. So when we go remote, we're going to kind of pause, going to turn these mics off. Person online, we're going to give them the thumbs up, and then they'll go to work. And so we'll eliminate some of that feedback we had yesterday. So those are a couple things. Mr. Co-Chair, anything else then before we take the roll and get this thing going?
I think you're right, solidly on target. I will mention that we have 2 members out that will be able to participate remotely after we redo our rules. Senator Pappas is actually in the hospital in Cheyenne. If he has an infection in his leg, it looks like he's doing okay. It's mostly precautionary, but he was very wise. He went down there last night. And I hope we have Senator James. And so your Senate guys are kind of light, but we will do our best, Mr. Chairman.
Very good. Thank you. Okay, with that, can we take the roll today? Is that Josh? Thank you.
Senator Baldwin. Here. Senator James.
Here. See your screen.
Yep.
He's got a thumbs up.
He's here.
Senator Pappas.
Here. He's excused. I believe he's going to join though. Oh, we're looking right. He looks better on TV. Here. He's here.
Senator Schuler. Representative Baker. Representative Gray. Representative Hallinan. Representative Henderson. Representative Jennings. Representative Roscoe. Representative Sweeney. Representative Yin.
Here.
Co-Chairman Case.
Present.
Co-Chairman Harshman.
Here.
We have a quorum.
Okay, thank you very much. Now, I briefly explained that rules. We adopted rules, the standard rules, and we had a couple amendments. One was the co-chairman. The second was requiring membership on this committee, the 13 of us, to be present to actually vote. That is contrary to what Management Council adopted. So I'd like us to back that up. Is there a motion on that?
I would move to reconsider that, ask you to vote yes on the reconsideration, and then we'll revote it and vote no.
Is there a second? Seconded on the so this vote now is to just really reconsider that rule. So we appreciate an aye vote to open this up. All those in favor, please raise your hand. Okay, that's 10 votes. All those opposed? Okay, 1. I'm with you, but okay. So that is passed. Now we're on this rule and really entertain a motion, Mr. Co-Chair.
We're just going to redo the motion from yesterday. And we would ask you to vote no.
Okay, so the motion was yesterday to prohibit remote participation by members of this committee, and Mr. Co-Chair is asking to vote no. Is there a second on that motion? Okay, seconded by Vice Chair Henderson. Okay, and then this would, a no vote will put us in line with Management Council policy. Clear on that? Okay, all those in favor, raise your hand. Okay, 1, 2, 3. Okay, all those opposed, please raise your hand.
You know, I always do what Management Council says.
I hear you. I did even when I was on Management Council. Right? 1, 2, 3, 4, 5, 6, 7, 8. Okay, so that's not been adopted. And 9, Senator Jane, saw your hand there. Okay, very good. Okay, so we've got that aligned, regardless of how we feel as chairman or members individually. We're gonna roll with that until we see otherwise. Okay. No other housekeeping items. I mentioned the audio piece, and we'll go from there. So the first item on our agenda today is Medicaid expansion. And we have the Department of Health, the director, and your able assistants. And so the floor is yours if you would. And I just remind folks, first of all, we really appreciate you. I'm looking throughout the room. It looks like a pretty experienced group. We always will address the chair. We'll work through all this testimony, give folks here in the room first the opportunity to address the committee, and then folks online. And so we appreciate you being here. Please introduce yourself, and floor is yours.
Chairman Harshman, members of the committee, I'm Michael Sabias, the Director of the Department of Health. And we're here today to provide information to you on the questions about Medicaid expansion. Let me first start with the fact that in '95, I think I started working with the legislature and I was a lobbyist. So I have the totally different role here. My job is not to lobby for a position, but help answer the questions you have. And I think between our team, one of the interesting parts, in fact, some of the members here told me that we have a really good analytical team. And I would have to tell you, I'm very confident in what they will produce for you. So the answers that we give you, I think, will be accurate and they'll be within the ranges that we talk about. And if you have questions for us, if we can answer them now, we'll do that. And we are also able to get back and get answers back to you if we don't have the information directly. So today, what we're going to cover is just background on Medicaid expansion, generally some summary of the costs of it, the ARP incentives that are there, and some of the effects on the numbers of folks that'll be impacted with this, the methodology of the overview of the methodology that we're using, and then the effects of Medicaid expansion. So Stefan Johansson is going to present that. We do have Franz Fuchs here with us that, again, did a lot of this analysis. So I think our team's ready. And with that, I just pass it over to Stefan.
Morning. You're on. You know, these things you can't see, the light is back behind you. There you are. Yeah.
Thank you, Mr. Chairman and members of the committee. My name is Stefan Johansson. I'm the Deputy Director for the Wyoming Department of Health. As Mike mentioned, we wanted to provide a little bit of an overview. I know that several members of this committee sat through some of these presentations during the session, either on the Revenue Committee or on the Labor Health Committee. So we tried to just provide you with some of the summary highlights. But as Director Sabias mentioned, we're more than happy to answer questions or go dig up additional information and follow up with you after this committee meeting. So if you'll turn to slide number 4 in your presentation, and in the spirit of budget reductions, we did put 4 slides on a page to save on printing. So hopefully it's not too small, but you should be able to see it on the screen as well. In terms of just background on Medicaid, Mr. Chairman, for those of you who might be new to the issue or new to the Medicaid program, Medicaid is different from Medicare, but it is a joint state and federal program that provides medical care and long-term care. And I want to stress this to certain categories of low income or medically needy people. The reason I stress categories is because currently in Wyoming, you cannot just be low income and qualify for Medicaid. You have to meet a certain, what we call categorical eligibility requirement. Certain types of disabilities and certain types of conditions will qualify you for Medicaid currently in Wyoming without the expansion of Medicaid that was offered by the Affordable Care Act. Turning to slide 5, Mr. Chairman, speaking of the Affordable Care Act, just by way of background, I think this is useful information since it has been 6 or 7 years since we began these conversations. The original drafting of the Affordable Care Act did contemplate that all individuals under 138% of the federal poverty level would be covered by Medicaid. That was essentially a mandatory provision in the original drafting of what passed in the Affordable Care Act. However, a couple of years after that, in 2012, the Supreme Court ruled that the mandatory expansion of Medicaid through the Affordable Care Act was unconstitutional. And so that's what effectively rendered this decision to be optional for states. That's why we're here. That's why for the past several years, we and you all have been talking about Medicaid expansions, because the courts ruled that the federal government could not require the expansion of Medicaid through the way that it was drafted in the Affordable Care Act. And that really leads to some of the issues that we'll talk about and we'll summarize in the slides to follow. On slide number 6, Mr. Chairman, again, just to close up some of the background section here, currently 39 states in the District of Columbia have expanded Medicaid, and 12 states have not. You can see the 12 states in orange on the map that's provided there on slide number 6. And again, just as a reminder to the committee, Medicaid expansion in terms of implementation became an option, essentially turned on in 2014. So we're about 7 years into the availability of Medicaid expansion through the ACA. Mr. Chairman, your next slide.
Yeah, go ahead. Representative Gray, you mind if we is that easier for you? We'll
Your
just
preference, please.
interrupt while we go and have those questions per slide. Okay, Representative
Thank you,
Gray.
Mr. Chairman. So a couple questions here on slide 4, the statement that work requirements are unlikely to be approved by the Biden administration. So, I mean, Indiana, right, has a work requirement. A lot of states have a work requirement. Are they not approving those, or has that already been grandfathered in? I mean, how is that not coercive? You know, how is that, first of all, equitable that a new state coming in would not be able to have a work requirement, and one like Indiana that already has it does?
Go ahead,
Mr. Chairman, Representative Gray, it's a good question. Slight bureaucratic tweak to the term work requirement in Indiana or Kentucky. Those states have community engagement requirements. So some of the original proposals of actually being required to be working or seeking work has not been approved. But in terms of the statement here on slide number 4, we have had indication from CMS that work requirements or community engagement requirements as a condition of eligibility for expansion are not going to be approved. So again, that doesn't mean that a Wyoming plan couldn't include some of those provisions in terms of negotiating with CMS, but we're just giving you the information that we know right now, that some of those provisions, like premiums being assessed on the population or work requirements, it's unlikely with the new administration.
Okay, thank you. Go ahead.
Thank you, Mr. Chairman. You know, I want to talk a little more about this coercive element, because, you know, I remember when they ruled that this section was unconstitutional. I actually went down to the chamber that day because I thought they were going to rule the whole thing unconstitutional, and I thought that would be a seminal moment in our country's history. But you know, I feel like this is pretty coercive where we're at right now. I mean, I think you look at slide 6, the number of states that have done this. So is there any potential challenge that is in the works to where we're at right now, where they're dangling money to the extent that I feel that it's way past the line of being coercive? Have you heard of any legal
Go
challenge?
ahead. And then we're gonna keep on moving. Go ahead.
Mr. Chairman, Representative Gray, I think the legal challenges that I'm aware of so far have been mostly resolved. To your point about coercion, or maybe a better term is incentives, you're right. The new ARPA, there are incentives for Medicaid expansion. I would say, looking at the map there, the dominoes continue to fall. States continue to elect to do Medicaid expansion, and I find it to be similar to how the Medicaid program rolled out since the 1960s, where not every state, it's a mandatory program as well. Not every state elected to join early. I think Arizona was the last state to join Medicaid in 1982. But you know, no judgment call or value judgment there from my perspective, only that the incentives are there and you can see kind of where the trends are going.
They were the last state to join the union too in the continental United States, or they state 48. Yeah, okay, very good. Thank you. Continue, please.
Thank you, Chairman Harshman. Moving on to slide 7 and slide 8, you can see we've broken this out to really give you a sense of the kind of coverage availability for the various populations as it relates to Medicaid expansion. On slide number 7, you can see in the left-hand column, we've broken that out by the percent of federal poverty level and kind of what the coverage options in expansion and non-expansion states are. I want to point out in your 0% to 138% rows, kind of your first 2 rows there, you can see what I was mentioning before with the Supreme Court ruling that Medicaid expansion would be optional. It essentially left what we call this coverage gap. And that's what you'll hear a lot when you have discussions about Medicaid expansion is the coverage gap. And essentially what that means, you can see it in red, is for a certain percentage of the low income population in non-expansion states, those populations do not currently qualify for Medicaid. And those populations do not qualify for the premium subsidies on the Affordable Care Act exchanges, the Obamacare exchanges. Again, going back a couple slides ago, you'll remember I said that the Supreme Court ruled this expansion optional because the original ACA contemplated that this whole population, 0 to 138%, would be on Medicaid. Since that's now optional, that's where that coverage gap comes from. Those premium subsidies and then Medicaid eligibility are not available for that particular population. Moving to slide 8, really the same data, the same.
Can you just,
Sure.
I think just spend a little more time on that. It's small on this sheet, so I'm trying to, but I think just take us through what, the non-expansion side and the expansion side, and just kind of take us through maybe those first couple tiers from 0 to 100 and 101 to 138 and then above 139. Just kind of lay it out for us again.
Mr. Chairman, absolutely. So moving through those different rows, the first kind of row there is your 0 to 100% of the federal poverty level. I don't quote me on this, but I think the most recent 2021 individual income standards. So at the poverty level, 100% of the poverty level, I believe is around $13,000 a year of income. Again, that scales up depending on your family size, but that's 100% or right at the poverty level. So anything below that in terms of one individual's income would fall into that first row of 0 to 100% of the poverty level. That's the group, Mr. Chairman, that because of some of these issues with how the ACA rolled out, that's really your coverage gap group that doesn't qualify for subsidies for insurance. So really at that income level, I think it's safe to say without subsidies, insurance is likely unaffordable. And then also in states like Wyoming or other non-expansion states currently does not qualify for, that population does not qualify for traditional Medicaid. And that's really that red box that you see there where there's really no subsidy available. And so that's typically your uninsured population.
And then as you go across, obviously the expansion states.
Mr. Chairman, that's right.
Walk us through that.
The purple box is there. If you look at the expansion state columns, you can see that for that population, 0 to 138%, that's where Medicaid then kind of steps in to fill that role. And it has been implemented in different ways across different states. So some states have just done a vanilla straight Medicaid expansion, and other states, to Representative Gray's point, have done certain other elements with expansion, a lot of which require waivers. So things like assessing premiums on your higher income expansion folks, experimenting with community engagement requirements subject to federal approval, healthy behavior incentives, certain things like that Wyoming and you all and us have discussed over the years. But that purple box really is what fills that gap in the expansion states where coverage would not be otherwise available.
So then the next group, 100 to 138, and then, so it's not a red box, but explain really the difference between that 138 and 139 on the benchmark premium for the subsidy, if you would, please.
Mr. Chairman, absolutely. So again, going back to the original drafting of the Affordable Care Act, subsidies on the exchange, on the Obamacare exchange, are currently available to anybody over 100% of the poverty level. So currently that population in Wyoming does qualify for pretty generous federal subsidies. Now, if we expanded Medicaid, that population would move over to Medicaid, the 100 to 138%. And we'll talk about that a little bit later in the presentation. But currently that part of the expansion group in Wyoming does qualify for subsidized private insurance. The group below them, so the 0 to 100% group, really, to put it bluntly, does not qualify for anything currently.
Go ahead, Mr. Co-Chair.
If I could tag on a little later, are you going to provide maybe numbers of the people in the two groups? Appreciate it.
Mr. Chairman, absolutely.
All right. And I don't want to drill too far on this, but from 138 to 139, and then the difference in the benchmark premium cap that I think it's 2.07 and then 3.1. I mean, literally, you're talking a couple $100.
So, Mr. Chairman,
Little cliff effect, yeah.
Mr. Chairman, you're right. And you'll see we note there the small cliff effect when you get above that 138% threshold. I think what's important to note here is anything above 100%, so all of the rows remaining kind of going up to 400% of the poverty level, that's really what the Affordable Care Act intended to be your subsidy group. That's the group that qualifies for some level of private insurance subsidies. And it really, that subsidy kind of ratchets down as your income goes up. Now with the ARP, the American Rescue Plan of 2021, we have already seen changes to the private insurance on the exchange where subsidies have now become more generous, even for your population above 400%. But we're still kind of monitoring how that's rolling out. That's very new.
Thank you. Representative Yan has a question.
Thank you, Mr. Chairman. Mr. Johansson, thanks for this chart. I think it's really good. Do you happen to know what the cost for the cheapest unsubsidized ACA plan is?
Mr. Chairman, Representative Yin, you said the cheapest unsubsidized plan?
Yeah, so something that someone below 100%, if for some reason they had the money magically, would be able to apply for.
Mr. Chairman and Representative Yin, I'd have to get back to you on the exact number, but an unsubsidized, sort of fully loaded plan on the exchange, I believe you're around $500 or $600 a month in premium, but I'll get back to you on that. We have those exact details.
Mr. Chairman?
Yeah.
So I think that would be 600 times 12 would be literally more than the upper bound of someone under the federal poverty level would be able to make.
Mr. Chairman, Representative Yin, it depends on the person and what their income would be, but it could be significant. Yes.
Thank you, Mr. Chairman.
Okay, sorry to get us bogged down there, but I wanted to make sure we understood that chart. Okay, I think we're on slide 8.
Mr. Chairman, slide 8, really, again, the same data, the same type of chart.
Mr. Chairman.
That time it's kind of broken out by age group and includes a little bit more
Mr.
of
Chairman.
what additional Medicaid program covers. So you can
Mr. Chairman.
see ages on the left-hand column, as well as your types of categories. And you can see really with your light blue bars what Medicaid currently in Wyoming covers and the poverty levels with which the eligibility standards are set. I'll just notice, similar to the red box on the previous slide, you can see the gray boxes here, again, is where that coverage gap kind of falls into place. So parents and caretakers, between 47% and 100% of the poverty level, as well as non-disabled adults up to 100%. That's really what you can consider what would be your expansion population that currently does not have coverage either through Medicaid in Wyoming currently or through ACA subsidized health insurance.
Okay.
So, Mr. Chairman, flipping to slide number 10, we want to get into a little bit of the summary. Again, just going back to our previous presentations and our report, which I believe you all have, that's much more comprehensive. We'll just hit some of the highlights here. On slide 10, to summarize our cost estimates and projections for Medicaid expansion, we projected on the first biennium of expansion only. And the reason for that, we really tried to be conservative in our projections and estimates because of the experience of other states where they really have under projected their enrollment and under projected their cost. So for the past several years, we've tried in our methodology to really adjust for that and use the experience of other states to try to give you all the best information. Policy is your decision, but we want you to have our best guess, our best facts on expansion. So we estimate that in the first biennium, that it would cost the state approximately $20 million in general funds, reminding the committee that expansion currently, and we'll talk about the ARP differences and incentives here in a little bit, but generally speaking, Medicaid expansion is currently financed at 90% federal match. So there is a 10% state match that's required. And so considering that and given that, we estimate that in the first 2 years of expansion, it would cost the state of Wyoming $20 million to cover an estimated 24 or 25,000 individuals who would be covered. And you can see that projection in the charts there on slide number 10. As I mentioned, Mr. Chairman, on slide number 11.
Yeah, go ahead, Representative Gray.
Thank you, Mr. Chairman. I'm really perplexed by this decision to only do a cost estimate for one biennium. When I vote on a law, I have to think about the effects on our children, our grandchildren. I mean, I view it as a potentially perpetual deal. I mean, yeah, it can be repealed, but it's very difficult to repeal something. So why are we only projecting for one biennium, especially with all the incentives that are out there that are gradually going to turn off? I think that's, I find that very problematic. Thank you.
Mr. Chairman, Representative Gray, it's a great question. And the reason is really because of the uncertainty that comes with this type of statistical projection in out years. We can certainly provide that, and a lot of that is included in the report. But it really does get more uncertain in out years. I think it's safe to say that $20 million for the first biennium is at least replicated in out years, but that population does grow and we can provide that data. It's really just difficult for us to statistically say, here's what the cost would be in 2026, 2027. So that's the reason that for this report, we only projected the first biennium.
And maybe you can follow up with us, later, kind of give us the worst case, of growth that you've seen in other states. And maybe, I know you're basing this on experience of other states, but show us the ranges maybe. Thank you.
Mr. Chairman, absolutely. Moving on to slide number 11, some of the changes that we're seeing from the American Rescue Plan. Specifically, it's really one element that I think you all are aware of or have heard about. The American Rescue Plan does offer an 8-quarter or a 2-year incentive for states that have not expanded Medicaid to expand. And essentially what that incentive does is it provides a 5% match increase for your traditional Medicaid population. So it's still 90-10, 90% federal, 10% state for expansion. But for 2 years, if you expand, and based on what the American Rescue Plan offers, there's a 5% match increase for your traditional Medicaid population. So we've worked out those numbers and we estimate that on gross, that 5% match increase for our traditional Medicaid population would equal about $54 million in that first 2-year period or in that 8-quarter period. Less the cost of expansion to the state, so the $20 million cost of expansion, the net savings would be, we project $34 million in that first biennium. I'll stress with this incentive or bribe, as I've heard it called, from the federal government, that is temporary. Unless Congress changes that to extend the incentive or to make it permanent, it is only in the law available for the first 8 quarters of expansion. And it is written so that when the state, whether it's Wyoming or another non-expansion state, when the state expands, that's essentially when those 8 quarters begin. There's not a date certain when that terminates in the rescue plan.
Go ahead, Representative Gray.
Thank you, Mr. Chairman. So on the last slide, it says you only project it out for 2 years. at least the hard, fast projection. And then on the next slide, it says that this incentive is only for 2 years. So are you considering the incentive? Are you netting that incentive into the previous slide? Because that turns off after your projection. So that means you're going to add at least $54 million or net savings of $34 million that's not considered here.
Mr. Chairman, Representative Gray, the biennial projections align with the 8-quarter incentive. Now, obviously, if Wyoming, elected to expand 2 years from now, we would have to update all of these projections based on demographics, based on what we project to be utilization and cost. But the 2 years that you see projected on slide 10, we're aligning with slide 11. So the second thing I would say, Representative Gray, is that what we've done in the report, absent any incentives, because we did that prior to the ARP, is to say, here's what we think without any incentives, without any cost offsets, without any cuts in the budget in Wyoming to finance something, here's what expansion we estimate would cost in state general funds. So that's what you have on slide 10. And then on slide 11, we incorporate that into a new incentive that was introduced through the rescue plan.
So who has, Representative Baker?
Thank you, Mr. Chairman. I just want to clarify and make sure that I heard you correctly. You said that the expansion in this incentive starts when we expand. So really, there's no necessity that we do this in the special session, is there? I mean, if we can catch these 8 quarters and catch the full 8 quarters during a general session, we could still do that. Is that correct?
Mr. Chairman, Representative Baker, that is correct. It's the 8-quarter incentive is available when the state elects to expand.
Okay. Representative Yen.
Thank you, Mr. Chairman. So maybe to restate the slide a little bit, would you say that if we do it for just 2 years, we would be cutting government expenditures by $54 million on the state government side?
Mr. Chairman,
34 million.
Representative Yen, yes, correction there would be on net. We estimate a $34 million offset to the general fund in those 8 quarters.
Are you going to talk about, I think the real kicker for me, I mean, is this opportunity on the FMAP. And I think I was a first-year legislator, 2003, and the FMAP changed, I think, sometime in there. And I didn't even know what it was. I wasn't even in my, are you going to talk about that in your presentation a little bit and those numbers? I mean, to me, that's a big deal. And I think you look at Montana's at 70% federal match, Idaho's similar, our 5 surrounding state average is 60% FMAP, and here's Wyoming 50-50. And really, in my mind, and maybe I'm going to have a leading question, this is what I think, and I want you to comment and correct me, but and these are the numbers I have in my head that I think the federal, it's based on average household income in your state compared to the national household income. The average national is about 55,000. Wyoming's 57. So we're above that. So we're going to pay 50-50. The issue is really Teton County that has an average household income of 230,000. And then when you weighted average that to the state of Wyoming, that puts us over the federal at 57. Without Teton County, we're like at 52. We're underneath the federal average. And so here we are. The rest of Wyoming should be at a 60-40 or higher match like Montana or somebody else. And so now we've got this opportunity because Medicaid, well, anyway, we've got this opportunity to maybe fix this FMAP because we have an outlier in our state. So, I mean, as we think about this and how we can have our executive branch negotiate with the federal government, to me, I see this as a way to maybe have a permanent fix on this. And maybe it's not the successful negotiation and we just move forward with what we got. But I think there's an opportunity to try this. I don't know, your thoughts on that and maybe how this whole, FMAP piece is figured out. I just think that's the key to all this for Wyoming, for our budget. It's huge.
Mr. Chairman, if I may, the conversation about Wyoming being at the statutory floor of traditional Medicaid FMAP rates is one that, whether it's me or Director Ceballos or our state Medicaid agent, we commiserate about a lot. We are one of 7 or 8 states that are at that 50% floor. So 50% federal, 50% state funds for Medicaid. And you're right, it's statutory. It's in the Social Security Act of how the FMAP, the federal medical assistance percentage, or the match rate, is calculated. Other states have, more well-to-do, wealthy areas where that really drags that FMAP down. I think in terms of negotiating a better match rate, frankly, Mr. Chairman, it takes an act of Congress to change the Social Security Act. We have had that conversation. We will continue. I don't disagree that if this effort or if this negotiation were to move forward, that's something to put on the list of how an incentive like this that's temporary could be extended to help states like Wyoming with their Medicaid financing. I think that's an absolutely appropriate topic, but just want to temper expectations in the sense that it is written into the Social Security Act. So it does take an act of Congress. And I think we all have our opinions on the action or inaction that's currently possible in DC. But point well taken, Mr. Chairman. It is something that is frustrating when our neighboring states, as you mentioned, do have these higher match rates, which really does ease the financing burden on state budgets, especially in a time like this.
Sure, Utah, all of them. Okay, thank you. Doc Hallinan.
Thank you, Mr. Chairman. Would you care to comment on the fact this is a discrimination against Wyoming if we don't enact the Medicaid expansion? And would that not be grounds for us to sue the federal government to give us this 5% more without enacting the Medicaid expansion? Thank you, Mr. Chairman.
Mr. Chairman, Representative Hallinan, I will unfortunately choose not to comment. That legal decision would be certainly above my pay grade.
Okay, I think Representative Yin had a question.
Thank you, Mr. Chairman. So, Mr. Johansson, since you were saying it would be an act of Congress to extend the FMAP past 8 quarters, the FMAP change, do you think that it would be important to ask any congressional candidates during election season that it might be useful to fix our FMAP
All right.
for the future? Thank you,
Yeah,
Mr.
I
Chairman.
think that one's not in your wheelhouse either. Okay. So, okay, we're gonna move on. Keep moving. Okay. Yeah, go ahead, Representative Baker.
Yeah, thank you, Mr. Chairman. While we're comparing other states, I have a quick question about the exchange. Wyoming has limited options, obviously, which I think is very difficult because I think one of the things that if we're going to talk about the federal government, we should look at affordability because, some of these people in these lower categories can afford car insurance, but they can't afford health insurance. And I think a lot of that has to do with the, options. So, when we talk about this, I think options is big moving forward. If Wyoming is going to be stuck with only one exchange, I think that's going to leave us in the same predicament for the class that's not going to be covered under Medicaid expansion. Myself, maybe, who doesn't have insurance, full disclosure, and hasn't had health insurance like other people, some people on the committee. But, beyond that, how many other states just have one option for their exchange?
Mr. Chairman, Representative Baker, it's a good question. I will double check this. I believe we are the only state that only has one provider on the exchange. I could be wrong, so I'll get back to you on that, but we're at the very best one of few. I think in terms of the options that are available on the ACA exchange, it really dovetails and is kind of a dynamic with what the law requires. So in terms of the affordability that you mentioned, that some low-income folks can afford car insurance, I think that's the difference in health insurance now since the passage of the ACA. It's what's required to sell a fully insured product or an insurance product on the marketplace that has to cover certain things. That's where, when there's no subsidies available, I think the affordability question comes into play because of what, frankly, the federal law requires in terms of what that insurance product has to cover. So prior to the Affordable Care Act, and even if you rewind decades, I think insurance products, largely covered catastrophic expenses, had very high, deductibles, but lower premiums, right? and didn't cover the range of services, the range of medical coverage that now the Affordable Care Act requires. So that to me is what generates the affordability conversation, is what the product has to offer. But I will double check. We'll double check if we're the only state that only has one provider on the exchange, but I believe we are.
Okay, thank you. Okay, please continue.
Mr. Chairman, slide number 12, again, just going to the summary of our estimates here. Like I mentioned, we project approximately 24,000 folks to enroll in Medicaid expansion in Wyoming within that 24-month or 2-year period. You can see some summary statistics here on this slide, but we'll, for the sake of time, go ahead and move on so we can get to
How many
more
of
questions.
those do you have? I mean, many are women, is that correct?
Mr.
What's your
Chairman,
numbers
yes.
on? Most of them are actually on the under 35 group.
Mr.
Okay.
Chairman, I believe the majority of the expansion enrollees, I think it was in the upper 50% range, would be low-income women. Yes. But that data is all in the comprehensive report, which we sent to the committee. But we can certainly send that to you
Sure.
again.
But I
point it
think
out to you.
too, just people who are listening, just so we have the information, who these Wyomingites actually are. So most of them are folks who are 35 and under, women. And then the next big group is the 55 to 65 group.
Mr. Chairman, I believe that's correct. Obviously, when folks age into the 65-year category, most go on to Medicare.
Right.
But yes, I think the demographics, we certainly have that in the report and can touch on that in this presentation as
Okay.
well.
Thank you. Okay, I think we're on 13.
Slide number 13, Mr. Chairman, again, just the summary here, summary data on some of the effects of Medicaid expansion. We do estimate that provider revenue, so folks that
Can I back you up? I'm sorry. Back to 12. I'm sorry. I cut you off. I think that you were talking about the known impacts on members. You could just cover that real quick and then we'll flip over. Sorry.
Absolutely, Mr. Chairman. So what you see on slide 12, again, just very high level bullet point summaries from our report. We do estimate a small decrease in mortality for individuals between the ages of 45 and 64 that would qualify for expansion. And we'll touch on that a little bit later in the presentation. We do know that based on other states' experience, we will see an increase in healthcare utilization. That's a term you've probably heard referred to as pent-up demand for uninsured folks that then gain an insurance product like Medicaid. Will often see an increase in utilization, going to the doctor, fixing conditions or treating conditions. And then we do notice, again, from some more rigorous studies that have been done in other states, some improved mental health, at least self-reported mental health, and increased financial stability, which again, Mr. Chairman, we'll touch on a little bit later, primarily from a randomized controlled trial that was conducted in Oregon as a result of Medicaid expansion.
Okay, now we're on 13. Thank you.
Mr. Chairman, slide number 13, again, on some of these second order effects of expansion, we estimate that provider revenue will almost certainly increase. We do have a discussion on what we call the crowd out phenomenon, going back to that population that would qualify for expansion in Wyoming that is currently eligible for subsidies on the exchange. There would be kind of a swap where they would be taken off of the private insurance subsidized product and put on Medicaid, basically a swap of federal funds for federal funds on the financial side. But that's what we refer to as crowd out. And we'll talk about that a little bit later and what that means for provider revenue, since the private insurance carriers typically on balance pay higher rates than Medicaid. We've incorporated that into the analysis, and our analysis shows that providers en masse on balance in the state of Wyoming would come out net positive on the revenue side from Medicaid expansion.
Go ahead, Representative Gray.
Thank you, Mr. Chairman. So this slide and this point, I also find very perplexing in this whole debate. Every time I have a meeting with the hospital, or they'll have a different events, different things to lay out what's going on in central Wyoming. Every single time there's a slide about their bad debt, and Medicaid is listed out as a huge portion of their bad debt. And then as soon as that presentation is over, then it segues into a conversation with the hospital asking for Medicaid to be expanded. And it doesn't make a whole lot of sense to me, because if their cash flow problem is partially due to the provider reimbursement rates and the current Medicaid system, how is the answer to that? Or how is Medicaid expansion going to be? I mean, yeah, gross revenues may increase, but net, I mean, are they going to net? What's going to happen to their net income, basically, is my question. I mean, I don't think revenues really are the key question here. So I pose that to you as a question. It's very, I've asked this many times, but really have not gotten an answer to it, because I think it's kind of a recursive argument. So thank you.
Okay, go ahead.
Mr. Chairman, Representative Gray, we estimate that on net, providers would come out with an increase in revenue. And I think that's related to the volume of folks, of covered lives, essentially from Medicaid expansion, that would essentially, that population below 100% would go from no pay source to some pay source. And I think it's fair to point out we are statutorily limited in rates that Medicaid can pay. It's something called the Medicare upper payment limit, which generally we can't cross in Medicaid. And then also have to live within the budget that's set for us by the legislature. So the debate about Medicaid rates, I think we can have, but I think the reason we project that on balance, providers would come out ahead from on a revenue picture with Medicaid expansion is because of that volume of approximately 2/3 of that 24,000 population we estimate to be currently uninsured.
Okay, go ahead.
Thank you, Mr. Chairman. So I understand that because of the volume, their revenue would increase. I mean, the question is what's going to happen to their net income? And sorry, I wasn't the clearest on that. I mean, so have you projected that out? I mean, I understand it might be a question for Mr. Foley, but I wanted to get your side of it.
Mr. Chairman, Representative Gray, if I may, it really does vary by provider and by provider type. So happy to have that conversation on what we know about those providers offline. But on the projections here are really on a statewide basis.
That there's a net increase
Mr. Chairman.
to providers. Okay, Mr. Vice Chair.
Thank you, Mr. Chairman. You give me a demotion. I thought we were co-chairs. I thought
Oh, yeah, that's
I
what I
thought we were
said.
like buddies.
I think I said Mr. Co-Chair.
You said, I'm sure you did. Mr. Chairman, so I think this gets tangled up with how medical costs and reimbursement of hospitals is. It's a very, very tangled thing. It's not, it's more of a fully allocated kind of cost. It comes about where you take total costs and divide it by the number of folks. It's not the marginal cost of providing the service. So in economics, the marginal cost of providing the service to the marginal customer is the driving most important thing. And that would be a positive. That'd be good. But when you try to say, well, the fully allocated cost of emergency services or hospital beds or Band-Aids, those numbers are off the charts. And so, and hospitals, the accounting is kind of phony baloney, medical world, if you don't mind me going out there a little bit. And the fact that that's how you can get a $22 Band-Aid is because of the way this allocation comes about. But to use that same allocation, which it works great for reimbursement and it has some benefits, but to use that to say that a particular service rendered is subsidized or not, I think kind of crosses the line of what the true economics of this is. And anyway, it's in that space where my colleague, Representative Gray's question lies and the solution. And anyway, it's a way, wouldn't you agree, or is there, am I onto something? Question.
Mr. Chairman and Co-Chairman Case, I think that's right. Additional complexity is introduced with a kind of a multi-payer model where there's a certain level of opacity in this market where what the true costs are not always very clear, both to consumers as well as as well as the state, frankly. And you're right, cost structure varies by provider, and it really is depending on what types of payer arrangements you have. It's different for every provider, frankly. So that's very at the provider level. Representative Gray, to your question, it's very hard for us to estimate net income. So we've avoided that in this presentation. But again, on mass, I think from a provider perspective, statewide, we project that increase. But Co-Chairman Case, your point is well taken. The economics of healthcare are complicated and tough to sort through, especially when you have Medicare, Medicaid, private insurance, self-pay, all essentially paying different rates and covering different parts of the fixed and marginal costs.
Okay.
Mr. Chairman, moving on to slide 14. Again, the next few slides we'll just hit on very quickly, kind of touch on going back to the why do we continue to do this report? Why do we update our projections? And you can see here on the enrollment and cost methodology portion of this presentation, all of the states that we used in our modeling for this report. And you can see the original projection for those states' Medicaid expansion population is in light blue, and the actual experience is in dark blue. So again, like I mentioned before, we did see many states that projected X number of people would be part of their expansion population, and then the enrollment was much greater than that. So the reason that we've done this analysis over the past couple of years is to continue to use that experience so that we don't, as a health department, lead our decision makers astray and say, as you might recall from years ago, our original projection from a consultant study was around 17,000 members. Now we're 25,000 members is our best estimate. And we want to be clear and transparent and frank about that updating our methodology and updating this we've used the experience of other states to try to get you all the best number. So on slide 15, you can see, again, our projection should be based on actual experience or data or fully explained assumptions, which we try to do in the broader report. And then one thing I wanted to touch on is we really do try to quantify and model out that uncertainty. So not to frustrate you all, you'll see it in some of the slides that we'll present here in a few minutes, but you'll see wide ranges of uncertainty. But we try to collapse that as best we can statistically and through our methodology to get that best guess, within the best confidence that we can as a department. So on slide 16, you'll see the biggest unknown, the reason for these projections. The biggest unknown is enrollment. That's what we've seen in other states. And we really essentially used a three-part model to estimate this. One is the take-up rate. If the state elected to expand, how quickly would folks enroll, and what would that look like on a time basis? And then secondly, what's that growth? How much do we think those people that would qualify for Medicaid would continue to enroll in Medicaid expansion in Wyoming? So that's really what develops our percentages, our numbers, and ultimately our best estimates for expansion. On slide 17, probably will be almost impossible for you to view on a slide so small. It is in the report on a full page and might be a little bit better on the screen. You can see all of those states that I mentioned kind of modeled out how they worked into the Wyoming Department of Health's model for Medicaid expansion. So I'll just let you look at that yourself. But the point here is that we did try to account for all of these state experiences, both expansion states and their experience, as well as modeling out to see how the model worked, non-expansion states like Wyoming. On slide 18, Mr. Chairman, again, just to visualize this a little bit, you can see the 24,000 expected enrollment in our projections. That brown line and that dot, that's that original projection from, I believe it was 2015, from the Milliman study. That 17,600 number that a lot of folks probably remember that was the projection at that time, that would be the total Medicaid expansion enrollment. We have, as you can see, that projection has grown in our methodology to be more than that, to be around 24,000 individuals. Same kind of thing on slide 19. You can see the Milliman projection in these enrollment trajectories, Milliman being that brown line and that brown target. And you can see the density of our projections are really higher than that in terms of our projected enrollment. And that solid black line is really what we think is our best guess. All of this, it's a little bit of an eye chart, but you can see those are all in light blue. Those are all types of or enrollment trajectories that the model spits out. So you can see in really crazy scenarios, extreme on the left and extreme on the right, but the model essentially runs these iterations, and you can see based on all of these factors, demographics, utilization, et cetera, it is spitting out what you can see there in the middle, around 24,000 people at that 2-year mark.
Mr. Chairman.
Representative Sweeney.
Thank you, Mr. Chairman. So on slide 19, the dotted or the line to the top, which would estimate approximately 38,000. That estimate is, would you consider that worst case scenario in the first 2 years?
Mr. Chairman, Representative Sweeney, yes, that's essentially those bands that you see. So the small dotted lines on the outside of these iterations, that's essentially that 13,000 to 38,000. So maybe, for lack of a better term, best case to worst case scenario in a certain kind of 90% confidence interval, for lack of a better term. When you tighten that up to get, again, a best estimate or what the model's really showing is more likely, then you go to the 67% interval, and that's a little bit less. So 16,000 to 31,000. And then right there in the middle, our best estimate would be around that 24,000 mark.
So follow up, Mr. Chairman. So to get a number to the 38,000 lives, we would just simply divide the 24,000 lives by the estimate of the 20 million divided again.
So, Mr. Chairman, Representative Sweeney, put simply, yes, in this presentation and in the report, the same kind of uncertainty that you see here on enrollment is also on cost. So we have that on a kind of using a per member calculation modeled in with the utilization and demographics, what that cost would be. So if we reached a scenario where that we saw 38,000 individuals enroll, which we think is less likely, we certainly have those cost projections as well. Yes, Mr. Chairman, actually we'll move to slide 21. Again, just to kind of wrap this up on why use these simulation-based projections. The real issue here is that how many people enroll is not the only important question. So we wanted to answer the bell over the past couple of years on what kind of people would enroll, based on demographics, based on health status, who will enroll first based on people with certain conditions that we think would be kind of first in line to enroll to get this type of insurance. How many of the expansion population would be uninsured? How many would already have insurance? Some of the discussion we had earlier about crowd out. What services would they use? What types of demographics would describe them? So both on the poverty side, employment side, we think there's effects there that we tried to include into the model of how individuals like that would either take up Medicaid expansion or not, and how they might use services. On slide 22, again, simulation-based projections do offer, a range of flexibility for us to kind of set the rules of the game, be very clear with you all on our assumptions. Again, a lot of that is outlined in the report, but also allows us, as I mentioned before, to essentially model out and show you the uncertainty that we have from a statistical perspective on what expansion would look like. Mr. Chairman, slides 23 and 24, again, a bit of an eye chart, but we do on slide 23, in our model, we expect morbidity and kind of health status of the expansion population to be similar to what we call the Medicaid non-disabled population. And this category currently in Medicaid, we refer to as our family care adults. So very low income, below 50% of the poverty level, and caretakers. So caretakers of children or elderly children. That's essentially the population that looks to be most similar to what we expect the Medicaid expansion population to look like. So you'll see that throughout the report. You can see it here in what's been modeled out in a range of different types of conditions and how we expect those conditions to impact utilization. On slide 24, you can just see in certain types of service categories, outpatient, inpatient, dental, how, again, the phenomenon that we see typically with providing coverage to a previously uninsured population, your more unhealthy or folks with more conditions, essentially your sickest people tend to enroll first. And you can see that kind of in the per member per month across these different service lines. So if you just look at the outpatient, your kind of far right graph there, you'll see the per member per month on outpatient services starts relatively higher at around $200, $250 per month. And then as a more healthy general population enrolls in expansion, that per member per month will start to decrease. So just shows you a function of how the sickest people typically enroll first.
Perhaps a dumb question, but I noticed you have dental on this. So most private insurance doesn't cover dental. It's an optional coverage. And I have a question back to the two levels, the first, just 100% of the poverty level, and then the next level where you qualify for a subsidized insurance on the exchange. My question is, would one benefit of not having the subsidized services on exchanges, there would be some dental coverage? And what is the extent of that dental coverage? I have a follow-up after that.
Mr. Chairman, Co-Chairman Case, I'll have to follow up on the availability and comprehensiveness of dental coverage on our current exchange. I apologize, I just don't have that information with me. In terms of adult services in Medicaid, which would be offered to the Medicaid expansion population, dental is currently offered. You might recall part of our budget reduction conversation in this last session was to eliminate adult vision and adult dental coverage as part of the reductions, but joint conference and ultimately the legislature added that benefit and that funding back in for the next fiscal year. The point, Mr. Co-Chairman, that I would make is all of our services that are considered optional by the federal government, of which dental and vision are considered optional, those are always subject to budget conversations with the legislature and the availability for Wyoming Medicaid to offer them.
Mr. Chairman, may I follow up just slightly? So I actually think this is a pretty important issue. And I don't know quite how to explain it, but dental services are really important in this population. And I've kind of been on this crusade before when I was advocating it for our friends that have developmental disabilities. And so there's a systemic connection between dental health and your overall health. It involves your heart. It's really quite an incredible thing. There's also this issue about employability and having dental care to give you confidence to be in the workplace. And you would be just appalled, I think, at folks that are kept out of the workplace because of dental issues. To be in the public, you got to kind of have good teeth. I mean, it's an expectation of our society. So these kind of things, I just don't think we should underestimate. This is more huge than you know. And then at the appropriate time, I'd like to ask about maybe reimbursement for ambulance services throughout Wyoming, which I just see as this huge crying need that might be marginally helped by Medicaid expansion. But I don't know if I'm at the right place for that. And you can do it at the end. But these kinds of services, there is a little bit of apples and oranges thing because those folks buying private insurance on the exchange, they don't get dental. And it's really important. Anyway, I don't know how you want to work in the answers to that and the ambulance piece. It's at your leisure.
Mr. Chairman, Mr. Co-Chairman, happy to address that as we go. We have some initial data on what ambulance coverage would look like. I think to put it simply, having an uninsured population covered would almost certainly increase ambulance revenue, similar to other providers in the state. To be blunt, would it rescue Wyoming ambulance services? Likely not. We do have an issue, as other rural and frontier states do, with making sure our EMS and our ambulance system is healthy. Medicaid expansion, I think, on the revenue side would add additional revenue. And then in addition, kind of a dynamic that the legislature has passed is what we call an upper payment limit program. We've done that with nursing homes. We've done that with hospitals, essentially a way to collect provider fees, match it with federal funds, and redistribute back to providers. We are doing the same thing with ambulance services that will start to unfold over the months, and I think a year or so from now, based on what the legislature passed. So Medicaid expansion, because of the volume of people that would then be covered, would increase that, what we call UPL, or upper payment limit, ability to draw down additional federal funds and redistribute that to providers, essentially grows the pie. But in no way, I want to be clear, do we think or want to say that Medicaid expansion solves our ambulance issues around the state?
Mr. Chairman, that point's very well taken, but I do think, as desperate as we are with respect to ambulance services, having a positive impact is kind of big out there. And it might, some of my colleagues in the Senate, Mr. Chairman, you'll recall we affectionately call the leadership in the Senate the tiny town trio, because they're from very rural areas of Wyoming, from smaller towns. And it's an affectionate term, but they care about this, and this could make the difference when we get to the Senate. So thank you very much for that answer.
Thank you, Mr. Co-Chair.
Mr. Chairman, could I just ask
Representative Baker.
along that line? So my question is related to price transparency in these providers. I know that where I live, the vision providers particularly are limited where I live. And so, and I don't know that they even accept Medicaid. And so that becomes an issue, I think, because if we increase the population that's relying on a provider that doesn't exist, how does that impact those providers elsewhere? So my question is the price transparency. I thought I was under the understanding that the previous administration put a requirement on anyone that accepts Medicaid has to publish prices. Is that correct?
Mr. Chairman, Representative Baker, that's not my understanding with that specific requirement, but something I can certainly follow up on and see if a previous administration did that. In terms of essentially provider acceptance rates of Medicaid, I did want to comment on that, if I may, Mr. Chairman. Wyoming has been somewhat fortunate through both strategy and just kind of our nature as a state. We have very good provider participation in Medicaid across Wyoming. When you look at hospitals, physicians, other types of providers, more so than I would say urban areas. For example, we estimated in previous years that around 99% of physicians in Wyoming accept Medicaid in some form or will provide services to Medicaid clients, whereas in New Jersey, I think that measure was below 50%. That's a very good thing in Wyoming, and something that's federally required of us to monitor what they call member access. Every year or a couple of years, we have to do an access report because, to your point, if we offer coverage, health insurance coverage, and there's no providers to provide the service, then essentially what's the point? So we have had it's difficult, especially in difficult budget times, to offer rates that are attractive enough for providers to participate. But historically, Wyoming has been fortunate in that participation. It's just, it really is a mixed bag in different communities of what types of providers are available. So we know that folks in certain communities have to drive, and sometimes drive long distances to get care. It's really just kind of the nature of Wyoming, but en masse, we do have a relatively good provider participation compared to our surrounding states.
Okay, thank you. Continue.
Mr. Chairman, summarizing briefly, moving to slide 25, and I'll just hit the high notes here. We did some analysis in the report on the effects of Medicaid expansion, specifically on the members. And there's been, as you can see on slide 26, a lot of observational studies since 2014, which we're happy to share with the committee, point you in those directions. But we wanted to just highlight two kind of more rigorous studies that we've looked at in previous years. And on slide 27, you can see the Oregon study, which was kind of an inadvertent randomized controlled trial and can get into the details with you if you're interested on that. But essentially what this randomized controlled trial showed is some of the things I mentioned before. They did see increased health utilization. I think that makes sense when you get an uninsured population that then gains some type of health insurance. They did show and were able to demonstrate decreased financial hardship. So obviously catastrophic medical expenditures, certain types of medical debt were reduced. And like I mentioned before, self-reported health status increases and a decrease in reported depression were also part of the Oregon study. On kind of conversely, on the other side of the coin, interestingly, there wasn't a statistically significant detection of effects on physical health markers. So things that you would look for with gaining health insurance, that blood pressure improves, cholesterol improves, certain health conditions improved. And we want to be clear and transparent on this that I think there's benefits to Medicaid expansion. There's also things that I think have been oversold or maybe used in ways that isn't demonstrated by the data. And I think this doesn't just speak to Medicaid or Medicaid expansion. This speaks to health insurance in general, that health insurance is a very good thing for finances. This is a very good thing to spread, risk across a broad population. I think it's reasonable to say that we don't yet know, or we have some skepticism about the effects of health insurance specifically on someone's health. I think that's a broader conversation on, the type of person you are, your nutrition, your exercise habits, those kinds of things, where health insurance doesn't magically, solve longer term medical conditions. There was also an interesting study where that we call the IRS ACA mailing study, and I'll just hit this briefly. That in that study, essentially the IRS mailed out for folks to respond to determine if they had health insurance or not. And essentially what the study showed is a small but significant decrease in mortality among that population between the ages of 45 and 64. So if we take that and we just mirror that up with Wyoming's expansion population, or what we anticipate to be the expansion population, what you'll see in the report is that we would likely avoid 3 to 4 deaths on an annual basis. So 3 to 4 deaths per year in Wyoming could be avoided. Finally, Mr. Chairman, moving on in terms on slide 29, I wanted to talk about a little bit more detail on the effects of Medicaid expansion on providers. Slide 30 will show you kind of a breakdown of the different claims types, the provider category, and what we estimate to be kind of the in-state and out-of-state revenue from the expected utilization and cost of the Medicaid expansion population. Want to point out here that around 95% of what we show you as the Medicaid expansion cost, that is provider revenue. Medicaid administration, relatively speaking, is pretty lean, between 3 and 5% on an annual basis. So most of that cost, the $20 million state funds for 2 years, and approximately $150 million federal funds, that is 95% of that is revenue going out to providers in our communities to pay for services. On slide 31, Representative Gray, to your questions earlier, you can really see this modeled out, and again, would point you to the relevant sections of the report where it's not so eye-straining to see this. But this really shows you both on in inpatient and outpatient claims, as well as what we call professional services. So things like clinics and nursing services, that kind of thing. You can see the gray lines and the black kind of median there. That's the gross revenue increase on a statewide basis from expansion. Far below that in the orange lines, that's kind of the crowd out phenomenon of folks above 100% of the poverty level moving off of private insurance to Medicaid. So the kind of revenue decrease there to providers because private insurance typically pays higher rates. And then the balance would be that blue shaded area, and the projected line is kind of that solid blue line. So again, that kind of shows you modeled out in these different types of claims type and utilization of these members that we expect the net positive balance of revenue for Wyoming providers. Mr. Chairman, on slide 32, we did have some brief analysis of the effect of Medicaid expansion on private insurance. So just to keep belaboring the point, That crowd out phenomenon, like I mentioned, does move certain people who might be eligible for private insurance subsidies through the ACA to Medicaid if Wyoming expanded Medicaid. And we do think that Medicaid expansion thus is likely to take more expensive than average individuals off the exchange. So the point there is that with this low income population, because health status is really on a gradient with income, we do see lower income populations having more health conditions. That's demonstrated in the research and in the data. Medicaid expansion by that crowd out phenomenon would essentially take some higher cost members off of the exchange. And we have one provider on the exchange, Blue Cross Blue Shield. We estimate that taking some of those individuals off of their plans may have a marginal effect in decreasing premiums for private insurance. But I think it's that would have to be lived through experience. That's just something that we show in the analysis here as a potential.
Representative Gray.
Thank you, Mr. Chairman. So what is the Department of Health doing to try to get more than one provider on the exchange? Because I think that's a tremendous problem. And so what are the challenges to get more than one provider? On the insurance across state lines, I mean, I've been trying to craft a bill to get us there on that. I mean, you hear different things that, a lot of defeatism I've heard from the Department of Insurance on whether that would help or not. I think it would. So what can we do to get another provider on the exchange, absent just providing just handouts, like more dynamic kind of ideas, and can insurance across state lines help with that?
Mr. Chairman, Representative Gray, I do believe there's another entrant to the market, if not on, but maybe coming into the exchange. Not to punt the question, in terms of getting additional providers or carriers for insurance in Wyoming, it's not really a Department of Health mission. As you mentioned, it is more in the Department of Insurance world. My understanding, not to get over my skis, is that Wyoming state insurance regulations do currently allow for overstate line purchasing and selling of insurance, but again, that would be a question better suited to the Department of Insurance. From a policy perspective or an analysis perspective, I would say the difficulty in attracting health insurers to Wyoming historically has been, our long spaces between people and our low population. It's difficult for new market entrants to develop networks and have kind of that negotiating power with providers to make an insurance product viable. I think that's why Wyoming, after the ACA, does have limited insurance options. But again, I would stress that even with one provider, for this type of population, your lower income population, the vast majority of those insurance costs are borne by the federal government on the exchange, very similarly to how the vast majority of cost of Medicaid expansion would also be borne by the federal government.
Okay. Question, Representative Yen.
Mr. Chairman, I just wanted to provide some clarification. I did sign up for a healthcare plan on the exchange the beginning of this year, and the second provider is on there. It's Mountain Health Co-op. They're based out of Idaho, and so they are selling across state lines, essentially, into our state. Their plans were actually more expensive than BCBS, so I signed up for a BCBS plan.
Mr. Chairman, thank you, Representative Yen. I was not aware that had gone live, but that's, thank you for that clarification.
Mr. Chairman. So
Representative Sweeney.
also my time on labor health, I do believe there's already the ability for another insurance company to come in. It's not that we've restricted, but I think your analysis is correct. It's just not been feasible with our population density to make it work. So, but thank you.
Thank you, Representative Sweeney. Mr. Chairman, that concludes our summary presentation. Happy to stand for any questions.
Can you, before you, I mean, I'd like you to go through these next couple slides, just kind of go through them. I mean, I know you saved us some money, but you didn't save our eyeballs. for us old folks. So if you've got a couple more slides, so if you go to 34 and then 35 and just walk us through those, if you
Sure.
wouldn't mind.
Mr. Chairman, you can
I
really
know you've
see.
explained it, but I want to explain it again.
Absolutely. You can, what we're trying to get across here is that Medicaid expansion with that crowd out phenomenon, again, both benefits and bugs, depending on your perspective, crowd out, moving folks off of subsidized private insurance, essentially to federally subsidized Medicaid, if we expanded Medicaid. On the other side of that coin has a phenomenon of potentially essentially decreasing the risk pool of private insurers on the exchange by nature of the state taking some lower cost and potentially sicker members off of the exchange pool and putting them on essentially to the state roles of Medicaid, could likely have an effect of decreasing premiums. That's really what you see on slide number 34, is across those different metal tiers of the plans that are offered on the exchange. What potentially could change if the state expanded Medicaid. And I'd point you, Mr. Chairman, to the lowest row on that, kind of that dark gray box. That's really the population that we're talking about, over the 100% poverty level mark, that would essentially be taken off. That arrow that's pointing to that box, that population would be taken off of the exchange. And again, we think that would have a marginal benefit to the risk pool of the private market exchange and potentially have a premium reducing effect because some of those sicker, higher cost members come off.
Okay.
So slide number 35, Mr. Chairman, really just elaborates on that in the narrative sense, where we want to be clear that the cost decrease for private insurance, I'm not trying to sell this, as Director Ceballos mentioned, it's not guaranteed. It's something that we think is a potential, if just based on kind of the analysis and the data that we see on the exchange and as a result of expansion. But it's certainly not something that we want to say if we expanded Medicaid, you know, it's everyone's health insurance premiums go down. It's certainly not a guarantee. And it's also unclear if taking that population off of the rolls would decrease, premiums both on and off the exchange. So, I would also mention that, Mr. Chairman, Wyoming's unique in that a larger share, relatively speaking, to other states of Wyoming's population is self-insured through their business. So it has nothing to do with the exchange, has nothing to do with the marketplace for ACA insurance. And that's unique to Wyoming, where, again, we want to be clear that we don't think that you'll see a dramatic decrease in health insurance premiums for folks across the board by nature of Medicaid expansion being adopted in Wyoming. So hopefully, Mr. Chairman, that was a helpful explanation. Again, would point the committee to the broader report, and Director Ceballos, myself, our staff, we're certainly available offline for anybody who wants to dig in more into the detail, the pros and cons of various policy decisions with Medicaid expansion. But we really tried with this report and with this presentation to present what we understand to be the facts, as opposed to the judgment call, the value call, which I think is thankfully in your world and not ours, of should this particular lower income population be offered insurance through the public sector, through public financing, federal and state, or not. We avoided that, as you saw in the report and in this presentation. So we're really trying to just present what we understand to be the facts through these projections and through these models. So with that, Director, if you have any closing remarks, we're happy to stand for questions.
Any questions, members? I just want to wrap up on your last slide, and I want to hear it again, and I want folks to hear it. So these estimated 25,000 people, just give us the demographic rundown one more time. Just tell us what you know.
Sure. Mr. Chairman, I think the slight majority of that 24,000 would be women. We estimate around between 55 and 60% of that population is employed in some form or fashion. And again, we're talking about the population from 0% to 138% of the federal poverty level, so the full Medicaid expansion. We can certainly provide or point you in the direction of what we expect those age demographics to look like. I think it's largely in your 25 to 45 year old population. And again, more heavily skewed towards women and towards the employed. But again, slight majorities there, certainly not overwhelming.
Mr. Chairman,
Representative Baker. has
thank
a
you.
question.
Along that lines. So I see that you projected 3 to 4 deaths possibly could be avoided. Was there a projection as to what demographic those deaths would be in?
Go ahead.
Mr. Chairman, Representative Baker, that's a great question. I don't have it in front of me. I know we modeled that based off of that IRS study, that mailing study. I'll get back to you on that. I don't know if we have the demographic information or if we just kind of ported over the conclusions from the IRS study, but let me get back to you on that if I may.
Okay, members, any other questions? Representative Gray.
Thank you, Mr. Chairman. So on slide 30, Mr. Johansson, on the
If we could let's just move it back. There we go. Perfect. Thank you.
on the expected biennial cost, this portion that's itemized as administrative, is that just, can you explain a little more how that works?
Sure, Mr. Chairman, Representative Gray, it's a good question. Those administrative costs are things, staffing in the Medicaid program, as well as things like claims processing. So our claims processing vendor charges a certain amount per bill processed, basically, and other things that are federally required in Medicaid, like utilization review. So like other insurance products, we do prior authorizations on certain high cost or high utilization services that we require, the member and the provider to get authorized prior to getting it. A lot of those services like claims processing, prior authorization, utilization review are contracted out and not provided with state staff. So that administrative cost of 7.8 million, that's really what all of that is. And like I mentioned before, Wyoming Medicaid typically runs at around a 3 to 5% annual administration rate.
How does that compare? I want to piggyback off that question before you leave it, Representative Gray, and I'll come back to it. How does that compare to private? I know.
Mr. Chairman, it's a mixed bag depending on the carrier. The ACA did require that administration rates not exceed, I believe it's 20%. We do see private insurance, I think, more in that 10 to 20% administration than compared to Medicaid. And I would also mention, Mr. Chairman, that Wyoming Medicaid, in addition to a few other states, we have not implemented what is known as managed care, where essentially the Medicaid program contracts out with a private plan to administer its services, its payments. You typically do see higher administration rates in states that have done that because they're contracting out all of that operation essentially, and that adds to your admin load. Wyoming, operates its program in-house with the exception of some of those things I mentioned to Representative Gray, and typically runs a relatively low and lean admin cost.
Compared to other states.
Mr. Chairman, compared to other states, I think, yes, I want to do a more comprehensive analysis, not to throw them under the bus.
Go back to Representative Gray now. I had some more questions. I just wanted to piggyback on that question you had while it was still.
Thank you, Mr. Chairman. Is this administrative cost itemized on each bill or is it just amortized in? Is the bill itemized with an administrative cost? I'm just curious.
Yeah, Mr. Chairman and Representative Gray, within this analysis, I don't believe it's itemized. We just took our administration rate and applied that to how it would scale with Medicaid expansion.
Okay. Yeah, I'm going to get all of us here and then, because we have to turn off mics and do a deal, I'm going to move to our online.
I believe
Members
that's
in a minute.
based on 5%.
Okay, now, Mr. Chairman is up next.
Thank you. Back on the administrative costs issue, where are those administrative functions performed? Are they within the state of Wyoming or are they outside the state of Wyoming?
Mr. Chairman, Co-Chairman Case, the majority of them are in the state of Wyoming. So claims processing, things like that. But these are national vendors in many cases. So in terms of where they're headquartered, that can vary.
But the actual, if I could just follow up just a little bit, the actual kind of people doing the work are here. How about in the case of the private insurance available on the exchange. I mean, I guess there's only one provider, so I guess we could speculate where they are, but
Mr. Chairman, yeah, I think with the entrant of the new co-op that's on the exchange that I believe is based out of Idaho, the I would assume, and I think it's a question for that particular carrier on the exchange. I would assume most of the administration does happen here in Wyoming. I believe they're based in Cheyenne, but I know that Blue Cross, I think, is headquartered in Tennessee.
Mr. Chairman, this just kind of opens up, and I hope we'll hear from other witnesses in this regard. So if we can figure out through this to actually help out local economic units like hospitals, like ambulance services, there's an additional benefit to the expansion in terms of not of actually a multiplier effect within our smaller communities. And I hope we can maybe get into that. Maybe it's most relevant in terms of the hospital discussion and perhaps the discussion with respect to reimbursement of providers outside of the hospital situation. But this is just an important aspect of this that I hope we're going to be able to develop as we hear from others as we go forward. So just putting that out there. Thank you.
Any members of the committee before we move to on? Okay, Representative Jennings.
Thank you, Mr. Chairman. Health Department, glad to have you here before revenue. I was trying to think back. I served on revenue a long time ago, and I don't know that I've ever seen Health Department show up for revenue. And so that having been said, in the past, you guys have always gone to your home committee of health and labor. And so coming before revenue, I would think that you guys would put this more towards, I guess, the revenue aspect of this. Are there some health things that we've overlooked or that you didn't put in this that maybe before the health department? Because we're probably not made up of the health people as much. It seemed bizarre to me that it showed up here. It seemed like that. So are there things there that you changed in your presentation? Is there some health aspects to this that maybe if you were sitting in front of health and labor that maybe this committee should hear?
Mr. Chairman, Representative Jennings, it's a good question. And no, we didn't change any content of the report or really this presentation wasn't geared towards the revenue committee. It really does reflect the larger report of what the costs, what the enrollment, what the health impacts, at least as far as we can project, would look like. So I would just say we go where we're called. So in this particular case, we're summoned to revenue, and I believe Chairman Baldwin can correct me if I'm wrong. We gave a similar presentation during the session to the Senate Labor Committee, and prior in the interim, the Labor Health Committee is very familiar with this report and this presentation that we typically update every December or January.
Yeah, Chairman Baldwin, Labor Health, and I know when I chaired appropriations, it was given to our committee one time. Didn't make it out of committee, but one vote. Okay, any other questions by members here? And we're going to move to members online. Representative Gray.
Thank you, Mr. Chairman. Mr. Johansson, I want to get back to this American Rescue Plan deal. The group that's been pushing this consistently during my time in the legislature, I look back every year, there's been 3 to 4 attempts. And so, I think if I were to count it, we're probably at 15 to 16, the 15th to 16th attempt since I've been a member in my 5th year. And, I just remember on the floor, a lot of people saying, well, this is just the best deal that the state of Wyoming is ever, it'll never get better, is what they said on the floor. It will never get better. And then this happens. And so, I want to ask your comment on that because, it just seems like they want us to trust, the group pushing this wants us to trust that all their projections are right. And yet, one of the main things they were saying for 4 years ended up to be totally wrong, which is that the deal was only going to get worse for the state of Wyoming. So ask if you comment on that.
Mr. Chairman, Representative Gray, happy to. Yes, I think the politics of changing administration sometimes changes the landscape of these decisions. we have had conversations with the federal government on, even with the change of the new administration, of how the American Rescue Plan could be sustained. Could this be, could it be made even better? And I think the answer that we get is maybe. And again, it goes back to the act of Congress. The incentive right now is temporary. Could that be extended? I don't know. But you're right. I mean, the expansion started when it was available in 2014. It was offered for 3 years at basically 100% reimbursement from the federal government, and that ratcheted down. There's been discussions, I believe, bills introduced in Congress that would give that now to non-expansion states. So 3 years of 100% federal match to further incentivize it. So to your point, and that if they did that, the deal would get better, temporarily better. But again, can't comment on the likelihood of Congress doing something like that. But you're absolutely right. With the change of administration and some passage of new legislation on the rescue plan, the deal, at least temporarily, has improved.
Okay, so the original subsidy was 100%, as you mentioned, for 3 years, went to 90. Okay, go ahead, Representative Gray.
Thank you, Mr. Chairman. For me, it just calls into question the projections, not necessarily the Department of Health. I mean, I understand, I have some questions there too, but some of the statements that are made by some of the groups that are very supportive of this. My other question relates to the argument that the state of Wyoming at any time could remove itself from this if the state of Wyoming were to enter. And, I didn't ask you about this in the revenue meeting when we talked about this. But your statement from the session that, well, the administration has provided verbal guarantees, and this wouldn't change my vote on it, but I do think that the argument is problematic. And you said you had received verbal confirmation from the administration that the state could remove itself from any time at any time without penalty. I assume that's outside of the 8 quarters. But I mean, why don't they want to put it in writing? I mean, that's my question.
Mr. Chairman, Representative Gray, we have in the previous administration, so prior to the Trump administration, we did receive written confirmation that we could withdraw from Medicaid expansion at any time. I would say it's just a legal certainty. Medicaid itself is an optional program, which could be withdrawn from at any time. Medicaid expansion is also optional. My point during the session is, I think, not to put words in your mouth, but the legal ability to withdraw from a program and the political or policy decision to remove a benefit are two very different things. But we are 100% certain that in the current context of the law, unless that were to change by Congress, the state of Wyoming, if Medicaid were expanded, does have the legal ability to withdraw from expansion at any time. And we do, Representative Gray, we have that confirmation. We'd be happy to get that from the new CMS director if that would be something that would be of benefit.
Okay, thank you. Just any other questions, Mr. Representative Sweeney?
Thank you, Mr. Chairman. Just a comment. When I got elected, I was against Medicaid expansion. As over time, my time on the health department or the labor health committee pointed a different direction. And then we have taken this up in the revenue committee. I think it was 18 or 19. Took this on, saw some of the specific modeling that's been used again, because I think it's great modeling. It's very conservative, and it's not misleading at all. I'm sure you can poke holes through anything, but this notion that were we to know the pandemic was coming, and where the position of the state would be in, I changed my position at 19 prior to the pandemic. Did we know ARP was going to come along? No. So this notion that we should have known and not made those statements, I take issue with. But we have heard this before the Revenue Committee prior to this, so
I'd like to-
my limit.
Okay, thank you. I just have a question. You know, we received a lot of emails. Many of them were the same email, but it said taxpayer funded abortions will increase if we expand Medicaid. And I mean, I responded to a few of them. I couldn't respond to all. But I mean, we operate under the Hyde Amendment. Maybe explain that for everybody, because that's a big issue. I mean, the legislature is pro-life. I mean, there's no doubt in Wyoming.
Mr. Chairman, it's a good question. Yes, Wyoming Medicaid policy does currently follow the Hyde Amendment, where no federal funds or public funds are used to pay for or subsidize elective abortions. Our policy currently in Medicaid is based on medical necessity, so essentially life of the mother. If there's a required abortion procedure, that could be covered by Wyoming Medicaid. I believe in the last 10 years, we've seen one of those in Wyoming Medicaid. Now, I know there's discussion about the Hyde Amendment potentially going away under this administration and under this Congress in DC. Wyoming would still have the ability to set payment policy with its funds to continue that policy of not paying for elective abortions, even if the Hyde Amendment were to go away. So our position in the Department of Health is that if Medicaid were expanded, we do not foresee an increase in the public financing of elective abortions in Wyoming. That's our current policy.
So the Hyde Amendment, then no elective abortions. I just want, because there's people watching that care a lot about this issue. There's people here today care a lot about it. There's no elective abortions. It's for save the life of the mother, rape or incest. Is that the Hyde Amendment? That's how I understand.
Mr. Chairman, that is accurate.
And we've had how many of those in the last 10 years, Medicaid?
Mr. Chairman, one.
Okay, so I think that's an important issue. So by expansion of Medicaid, we are not going to somehow change that policy, because we're not going to do it. I mean, if that's the case, and none of us are not going to vote for it. So that's really important, I think, for us to get those facts out. The other piece I think we hear about, you know, about this crowd out piece again. And I just want to say, because I've heard this for years now, and I think, and I'm concerned about this crowd out piece. How many folks are going to move off private insurance? Is it going to hurt private insurance? Maybe you heard today it might actually help private insurance because you move some of the sickest, heaviest subsidized folks off of that. Just one more time on that.
Mr. Chairman, it's a good question. To reiterate, the population for Medicaid expansion would be from 0 to 130% of the poverty level. And currently the population from, thank you, the population from 100% to 138% currently qualifies for private market exchange subsidies. So if Wyoming expanded, that crowd out phenomenon is essentially the movement of that currently privately covered population, again, heavily subsidized with federal funds per the ACA, over to Medicaid. That's what crowd out is. And we estimate that out of the total 24,000 individuals that would qualify or that we expect to enroll in Medicaid expansion in Wyoming, that about a third of those would be previously insured or eligible for private insurance subsidies.
Subsidies.
Yeah.
So you move from subsidies on the ACA to expansion.
Mr. Chairman, that's correct. So like I mentioned at the beginning, kind of a swap of federal funds for federal funds in terms of the financing. In terms of the delivery, it's very different in having, you know, private insurance versus having public Medicaid insurance. So we want to be clear that that phenomenon is real. That will happen. And it has happened in other states where individuals that were eligible for those private insurance subsidies move over to Medicaid expansion. That would certainly happen in Wyoming as well. That doesn't mean the exchange, the private insurance exchange goes away. it means a sliver of that population that's currently covered would move over to Wyoming Medicaid.
I think, okay, appreciate that. Another question, and I'm just going to roll down these because these are concerns out there, and maybe Mr. Boley, Hospital Association, some of this, and I know Doc Hallinan, I've heard him say it, practiced medicine for a long time. When it first began, the reimbursements were pretty good. I'm kind of paraphrasing what I've heard you say, Doc, and it's decreased. And I guess, we hear about that as these reimbursement rates. We heard in a lot of emails that the quality of care, doctors' waits, Montana is used as an example, that wait time for services have increased, all those kind of things because we've lowered that provider payment. And I know what you just told us is there's actually a net going to be an increase.
Mr. Chairman, yes, I'll take those kind of in order. We do know that on balance, and it's not with every service, but on balance, private insurance typically pays higher rates on a per unit basis than Medicaid programs. That's certainly the case in Wyoming. And we know that with that crowd out phenomenon, reimbursement rates from private insurance to Medicaid from the provider perspective will go down. I think to our discussion earlier, you have to couple that with the increased volume of covered lives, where providers who may have, and especially in the hospital case, and Mr. Boley could probably speak to this better than I, currently providing uncompensated care versus providing care to an individual covered by Medicaid, you will receive a reimbursement rate. I will say that in Wyoming Medicaid, we try to cover as close to cost as possible, both statutorily and within our budget. And there's various programs, like we mentioned, that we try to implement through upper payment limit programs, gap payments with hospitals, nursing homes, physicians, now ambulance providers, where we try to make up some of that difference between cost and what the Medicaid rate is. Those things are underway, but there's no doubt about it. Medicaid rates are generally lower than private insurance rates, but it's coupled with that increased volume of the number of covered lives. That I think it depends on the provider of how they come out on net. To our discussion with Representative Gray, we avoided the net income analysis here on individual providers because it's just nearly impossible for us to do. But on balance, I think the revenue situation does come out on the positive side from Medicaid expansion.
And I think, and I'll kind of wrap my part up, and I'm just kind of working down some of these concerns I've seen expressed to me through email. The other one was Medicaid expansion will move us closer to a single payer medical system and lose that freedom of choice in the free market economy. I'm reading right from this email. And what's your comments on that? I mean, how much medical care is shoppable out there? All those things.
Mr. Chairman, that's a big question and a good one. In terms of, moving closer to single payer, I think there's kind of a yes and no there. I mean, anything offered through the public sector, whether it's Medicare, Medicaid, VA, insurance, that's all government purchasing power. And I think the argument is the more you deliver healthcare or any other service through government, you're moving more towards that consolidated purchasing power, consolidated delivery. So I think there's an element of truth there, but single payer healthcare is really a policy decision that has not been discussed in Wyoming, certainly. And I think with Medicaid expansion, you still have a very multi-payer system with Medicaid, with Medicare, with TRICARE, with VA, with private insurance on the exchange, with self-insured plans and small businesses. That certainly isn't going away in the Wyoming healthcare landscape until, and maybe it comes, there's a different federal conversation about what health insurance and healthcare delivery looks like. I don't think that's in the near future.
Part of this issue I see, it's not like you walk in your doctor's office, you see knee surgery, 8,000, and then you can walk down the block and, oh, I can get a cheaper price here. So you don't really get to shop it like a free market like that.
Mr. Chairman, that's right. Like I mentioned before, there is a lot of opacity. The healthcare market is very opaque in many respects. I think transparency is becoming more and more kind of the buzzword of the day, and consumers are getting more educated on what services in healthcare are shoppable. In Wyoming, it's an interesting point. I think it's easier to see that divide of what is and what is not shoppable. For example, in a smaller community, in a rural community, there's just certain infrastructure that people want to be there. So a hospital with an emergency room, the ability to have OBGYN services to deliver babies, et cetera. Those are very high. Ambulance services is a great example, very high fixed costs that on some sort of regional basis, it seems like people need and want. Versus, more elective procedures or services that, Mr. Chairman, could be shoppable, and that's what you see, I think, in a lot of our border communities where there's economies of scale and larger populations. A lot of those shoppable services are accessed in the Front Range or Billings or Utah, et cetera. So I think there's kind of a divide between kind of critical, necessary, and emergency infrastructure that's very high cost, and then shoppable services, which often, from a business perspective, subsidize those high fixed costs. So it's a big issue, a kind of a sticky wicket from a policy perspective. But again, the expansion of Medicaid, in my estimation, does not dramatically alter that landscape in Wyoming.
Okay, and I just want to finish my last question. I know I've kind of hogged this mic here a little bit, but I want to finish where I started with the abortion issue again. Because one of the examples was Alaska. And, when Alaska expanded, their abortions increased by 25%. And I think there's more to this story as I've dug into this, and maybe you can share that with us. Go ahead. Any comments on that?
Mr. Chairman, my understanding is Alaska has elected to cover abortions, and because of the Hyde Amendment, they're unable to do that in their Medicaid program with federal funds because the Hyde Amendment prevents that. They cover that. Again, my understanding, we can confirm with the state of Alaska, I believe this is the case. They cover their abortion services in Medicaid through state funds only. That is the opposite of Wyoming Medicaid and Wyoming's policy currently. We do not cover elective abortions and do not anticipate to do so.
So we'd have to appropriate that as a legislature, allow you to do that.
Mr. Chairman, yes, I think that is fair to say.
I think chances of that are probably slim and none, right? Okay. Senator Schuler, thank you for your patience with my questions. Thank you.
Thank you, Mr. Chairman. Just to probably put you on the spot a little bit, Mr. Johansson, I'm separating the potential benefits, health benefits of Medicaid expansion, just putting those to the side. Do you see Medicaid expansion as a potential revenue driver for the state of Wyoming, a potential, job enhancement, maybe an improvement in the health of our hospitals and so on? Could you talk about that a little bit?
Mr. Chairman, Senator Schuler, a couple of points there from my perspective. Previous analysis with the Division of Economic Analysis several years ago projected a growth of approximately 800 jobs by nature of Medicaid expansion, largely in the healthcare sector. That's based on, I believe, what's called a REMI modeling. I'm not an expert on that. I think it's safe to say, is it exactly, it's not 799, it's not 801, but exactly 800 jobs is probably not the case, but some benefit because of the injection of that kind of revenue into any economy. I mean, we're talking $150 million of federal funds in a 2-year period. That's a lot of money. There's a multiplier effect there, likely has some impact on the economy, especially in the healthcare market. So I think there's some impact there. Obviously, on the revenue side, again, statewide, we estimate a net positive benefit to providers. On the state side, and I want to be clear here because I think over the years, to Representative Gray's point, some folks have said, Medicaid expansion will solve all the world's problems, and I think that's certainly not the case. Folks have said that it would be good for the revenue position of the state. What we want to be clear on is that with the introduction of the new ARP incentive, that's most certainly the most plausibly the case, is that we would see some benefit to the state revenues by being able to offset some general fund cost by the incentive that's in the ARP. Since that is temporary, we do not want to say that there's a benefit or a revenue increase to the state long-term from Medicaid expansion unless some other policy options are implemented. So the point there is we say it costs $20 million in this biennium to expand Medicaid. The question is, does the legislature elect to do it? Second question is, how do you finance it? And there's a variety of ways that states have financed it. One is through direct appropriations, through taxes, or through what are typically called cost offsets. So other state general fund programs that provide services to individuals currently with state funds, a lot of those populations, depending on the program, could be covered by Medicaid expansion. And you could finance Medicaid expansion by reducing that state exposure in some of those programs. So Senator Schuler, that revenue picture really depends long-term, ARP incentive aside, on state policy that would finance expansion.
Okay, thank you. That's how it was proposed before, frankly. Maybe list a few of those for the committee's benefit, some of those programs that could be offset.
Sure, Mr. Chairman. The population in some other state programs that would be covered by Medicaid expansion include corrections populations, and that is a little bit complicated in that you have certain medical costs for essentially corrections prisoners, folks like that who leave the walls of the prison. They're not eligible for Medicaid in the walls of a prison. That's a federal rule, but can receive federal financial participation when receiving longer term care, for example, in a hospital outside of the walls of the prison. That's a big offset of Medicaid expansion because a lot of that population could potentially qualify. The second is in community mental health and substance abuse, where that's a big state general fund expenditure. And a lot of those providers' clientele would fall into the Medicaid expansion group that would then
How much is that budget again? Just remind me again. Is that
after the recent cuts, Mr. Chairman, I believe it's around $80 million a biennium.
it was 50 million a year, roughly 100. It's down to 80.
Right.
State general fund.
And then, Mr. Chairman, there's a kind of a peppering of some public health programs that offer screening and treatment services for various conditions that could potentially, it's much smaller, could potentially be financed largely by the federal government with expansion. And so to your point, Chairman Harshman, that was a big discussion years ago when the legislature had commissioned us to study multiple options on Medicaid expansion. And one of those was tell us what other programs could be offset. So that, if that were a policy position for the legislature for us to do, we would renew those estimates and those analyses on what that could look like. But again, to reiterate my comments to Senator Schuler, it really is, to me, in my naive brain, does the state elect to expand, and then what's the vehicle to get there? And that's both financial and service delivery.
Thank you. Dr. Hallinan has.
Thank you, Mr. Chairman. One of the comments that you made is that the federal government is going to pay 90% of the amount for these Medicaid expansion patients. You also said that you have the authority, I believe, you offer higher rates of reimbursement than Medicaid ordinarily would give for these services that they provide to Medicaid patients. And so my question is the Medicaid administration back in Washington, do they have to approve these higher amounts? And are they obligated to pay 90% of those increases that you offer providers in our state? Thank you, Mr. Chairman.
Go ahead.
Mr. Chairman, Representative Hallinan, to put it simply, all of our rates are approved either through state plan or through waivers by the federal government. To clarify, my comment was we pay relatively higher rates than some of our surrounding states. And yes, in the Medicaid expansion population, if that were to be implemented, the federal government, essentially, if the claim is $100, the federal government would pay 90 for that expansion population, and the state would pay 10. For our traditional population, that FMAP rate and it has changed a little bit because of the pandemic. But generally that's a 50% match rate. And all of those rates are approved, again, either through state plan or through waivers.
Okay, thank you. Representative Jennings has a question.
Thank you, Mr. Chairman. So I actually have two and kind of a statement. So the insurance, I found it interesting that you said the insurance choices, all of them that you listed were already government, except with the exception of private insurance. So I thought that was kind of interesting that when we're talking about free markets and stuff, we're already narrowed down to one. So we're closing in on that single payer idea at least. So I want to circle back to the Hyde Amendment. So, and because your statement to that was that it was problematic of seeing what that was going to look like. So if that went away at the federal level, it would depend on how that went away, it seems like to me, because there are things in Medicaid expansion or Medicaid that are the feds have deemed you will pay for. And under the Hyde Amendment, that's not available to them. But with that were to be removed, as there are talking points now going on about it, then it would seem to me like that could very easily become an item that the feds would say you will pay for these subject matter, for this subject. So Wyoming, just a hypothetical, Wyoming would have to essentially put into law our own Hyde Amendment to keep you from doing that. And then that would put us at odds, or could put us at odds with the federal, depending upon how that comes down at the federal level. So I'd like to, that's one question. And actually I had an email from Representative Brown about having to do with the data breaches and stuff, having to do with how that correlates with expanding Medicaid. Don't know exactly where he's going with that, but I'm just kind of curious when he brought that up. Could you expand on that a little bit?
Mr. Chairman, Representative Jennings, to the point about the Hyde Amendment, I think you're right that any repeal that we see in Congress of that amendment, the devil would be in the details. And whether that's legal, law or policy from CMS, for example, how that would be regulated, how that would be pushed out remains to be seen. I think you're also right that if current Wyoming Medicaid policy, which is to not cover elective abortions, if we maintained that, to your point, could we, if the Hyde Amendment went away, could we see a challenge in the court that were contested that Wyoming should, but doesn't cover this? I think that's a possibility, but all hypotheticals that, again, we have to monitor that situation to see what happens at the federal level. In terms of the data breach that you mentioned, a bit of a separate issue, but something that I think folks are aware of. We did have some data that was inadvertently posted to a public site with COVID-19 results and breath alcohol results briefly. And so we've notified all of those individuals of that. Again, no social and security information, no banking information, but certainly a concerning breach, and we have federal responsibilities to respond to that, to investigate it, to notify people, to offer identity theft protection. Really completely different story than Medicaid expansion, where that's a totally different population. It's not. It's data that is kept in the Medicaid program, and there's obviously certain safeguards there. So this was an unfortunate incident that really not related to the Medicaid program at all.
Okay, thank you. Mr. Chairman. Yeah, go ahead, Mr. Chairman.
Thank you, Mr. Chairman. I appreciate the discussion of the Hyde Amendment, and I think we should be brutally clear about the path forward with respect to the Hyde Amendment and what are the what ifs. It is possible that I think that the Hyde Amendment could be reversed, repealed. But does that mean that the state of Wyoming has to provide elective abortions? Absolutely not. Absolutely not. I think this is very clear that it could come Can you imagine the federal government actually saying you must provide elective abortions? Now, I think some people can envision that, but personally, I can't. I really can't. I can't think that they would reach that far down. But if they did, we come back to the Mr. Chairman, this is an optional program. We withdraw from the program at that point. For some of you, you have to, and I understand that. But this is not the obstacle to implementing Medicaid that some folks would like us to believe. There's a path through it that prevents elective abortions in Wyoming under Medicaid at every step in the way. And that's the path we have to do if we're going to be together and move forward and get something out of the legislature. I recognize that. But we also have to recognize that we do control that. And the Wyoming legislature has spoken quite clearly on elective abortions. And Mr. Chairman, we need to go with that. We can even construct our bill to reinforce that. So, and put aside our own individual feelings and say, this is what's best for the Wyoming and the prevention of elective abortions under Medicaid is the policy of the state of Wyoming. We're going to do that. I just want to be clear that we control that, Mr. Chairman. And I appreciate your leadership here. And we need to unite on this one point. Thank you, Mr. Chairman.
Okay, thank you. I think Representative Yin had a question.
Thank you, Mr. Chairman. Just for the committee's edification, maybe the legislature as well, we do have a statute already in the state of Wyoming that no funds appropriated by the legislature of the state of Wyoming shall be used to pay for abortions, except in cases already presented by the good chairman. So even if the Hyde Amendment was removed, it would basically be illegal for us to stay in Medicaid if it forced us to allow elective
Statute
abortions.
number, just
It is 35-6-117, Mr. Chairman.
okay. Representative Gray,
You want to go, Mark? You can go.
were you?
Yeah.
Did
he
you?
was
Oh,
going
okay.
first. Is that
Representative.
okay?
I just have a
Yeah,
quick
please.
question, Mr. Chairman. Thank you once again. So in response to my good friend who gets me coffee, I have a question back to you because the issue that's brought up here is that, well, if this happens at the federal level, then what I'm hearing from you is that you're 100% convinced that from a legal standpoint, we can withdraw. And so I'm going to take you at your word at that we could legally withdraw. But then that brings to my mind 38 states. And I'm taking you at your word that then what it means is that 38 states have not, a single one of them, had the political will to withdraw. Am I understanding that correctly? That there's not, I mean, clearly we haven't seen a legal challenge, so it clearly must be a political body challenge. And so I guess my question back is I want to make sure I'm hearing that correctly, because that then makes it a question of legally we could withdraw, but politically in my 7 years, we have never come this close to actually doing Medicaid expansion. And so the political winds change. And so when I look at that and I think, well, okay, you might be right on the legal. I think you probably are right. But on the political will, no one's ever had the will to do that. And now, am I incorrect in that? Has there been legal challenges to withdraw?
Mr. Chairman, Representative Jennings, I would agree with you there. I'm not aware of any state that has wanted to withdraw from Medicaid expansion. I can't speak for their legislative bodies. I'm sure the opinions differ just like they do here. I'm not aware of any state that has said we would like to withdraw and the Fed said, no, you can't. I think that, again, I'm in agreement with you that the legal option is there. The political will to remove a benefit from any population, whether it's health, social services, or any other, is a different story.
Okay. Any other questions on the panel here? And then we're going to move online eventually. Okay, Representative Gray.
Thank you, Mr. Chairman. So I do want to weigh in on the Hyde Amendment issue. I think that the chances of a withdrawal would be very low. And I'm not sure that statute, how that would interact with federal funds. And I think they would probably word the Hyde Amendment repeal they would tie it to the federal funds portion. And that's how they try to put the squeeze on the states. And so it would put us in a very difficult position, especially if the state of Wyoming had already expanded, let alone the current Medicaid situation. So that's my opinion on that question. I do have a question for you, though, which is back on the hospital side. So I pulled up some FGA data that showed that Medicaid shortfalls grew by $5 billion after Medicaid expansion in aggregate in states, because revenues to hospitals increased 42.5%, but their cost to treat Medicaid patients grew by 50%. This gets to the net income question. I mean, I agree with you that revenues, net income's the question. And profit margins plummeted by 10% between 2013 and 2016 alone. Anyway, this is the FGA data. And so, I mean, I guess I would pose to you is just taking the net income question entirely off the table. I mean, I'm not sure that's a complete analysis. I mean, do you have any response to that? I know you probably want to look at the data, but I mean, do you have any response? Thank you.
Mr. Chairman, Representative Gray, I'm not familiar with that FGA report. I have had issues with their analysis and data in the past. But I think your point's a good one. And we didn't intentionally or overtly avoid the net income analysis. It's just almost impossible to do. So I think providers, as they have for years, are certainly welcome to testify on this issue of how it would pan out for them. I think some of the analysis I've seen, I'm not sure if it's FGA, suggesting that the bad debt and the financial hardship of providers really going in horrible directions is a little bit overblown, in that a lot of those providers are still in business. So if they're losing money day to day, week to week, month to month, then economics would dictate they would close shop, because Medicaid rates or any rates would not make them viable. So I think the providers or associations can speak to that better than I can, but would be happy to look at that data, Representative Gray, and discuss it with you.
Members here in person. Okay, now we're going to move online. We have 2 members online, and then we're going to take questions from them, respond to those. Then we're going to take a little break and get up and stretch and do that. So we're going to pause for a minute. Senator James, you're going to be next, but wait till I give you the thumbs up when I get the thumbs up here in the room. Thank you.
Thank you, Mr. Chairman. I just have a couple of questions. So my first question is, can you hear me now? Are you able to hear me now?
Senator, I think you're
Yes.
muted.
No, my mute's off. Can you hear me now? No? All right.
You muted?
No?
We cut back to us so we can at least.
No, I'm not muted.
Senator James, we're having a little problem. We couldn't hear you. We're going to try this again. Just make sure you're unmuted on your end. And we're going to try this again. I'm going to restart. Okay, and just 1 minute. I can actually leave my mic on, I think. Yeah. Tell me when you're ready. Okay, Senator James, try that now.
Can you hear me now? How about now? Can you hear me now? Anything?
Okay, Senator James, we're going to try Senator Pappas just to see if we can narrow this down. Senator Pappas, I see you're muted. Do you have a question?
He may not be available to talk
Yeah.
at this moment. He's actually in the hospital in Cheyenne.
So I think Senator James, maybe you can, maybe if we can type that question. You have the chat, and I'm not logged in, but I think staff is.
Oh, does that make sense, John?
Oh,
They can hear him on Zoom. The other Zoom participants can hear him, but we can't hear him.
okay, we're going to, Senator James, we're going to take a break, come back, and get this fixed, and we'll be back. So the time is 10:49. We'll come back at 5 after 11. Thank you.
Testing.
back on YouTube now, so, okay, we're back from our break. Folks, we're now going to move. We had some technical difficulties. We have two members who are with us remotely. Two senators, Senator James and Senator Pappas. A little problem. I'm
Hello.
looking, Senator James, I think it's coming on.
Can you hear me now? Are you able to hear me?
Yeah. Senator James, are you with us?
Yeah, can you hear me?
This is Senator Pappas.
Okay.
Can you hear me?
Senator Pappas,
Can you hear me?
are you with us? Are you with us? Are you?
Yes, I'm with you.
Are you able to hear?
Are you able to hear me? Can anyone hear me?
I can hear you, Senator Pappas.
Okay.
Can the
I hear
committee?
you as well too, Senator James.
Okay.
Testing?
We can hear you.
We can hear you. We can hear you. We can hear you.
Oh, you guys can hear us now? The committee can hear us?
I don't think they can.
How you doing?
Testing? I would try again, Senator James.
Okay. If the committee can hear me, give me a thumbs up. Okay, good. All right. So, Stefan, I have a couple questions for you, just two or three. On slide 14, regarding the consulting firms, did a consulting firm do our evaluation? If you could let us know who they are and what other states they have done, as well as if you could let us know who did Arizona, Delaware, Washington, Iowa, New Hampshire, and Illinois.
If you have any questions, go ahead and ask them all right now, Senator James, and then so we don't have another breakdown in our technology.
Roger that. And then my other question is if Stefan could give I want to say thank you for your list of all the positives of Medicaid expansion. I was wondering though, if you could give a list of why we should not have Medicaid expansion, and if you could prioritize by impact to the program and the redetermination process. And also, if you could let me know how many case managers does Ms. Green's department have? And that for the pre-approval of Medicaid inpatients. And those are my questions. Thank you.
We're switched over. Thank you, Senator James. We got all those questions. Mr. Johansson.
Thank you, Mr. Chairman. Senator James, I'll take those in order. I don't have complete answers to all of them, so we can certainly follow up. In terms of the consultants that did the original or early Medicaid projections in a lot of states, similar to us, I know Milliman Inc. was doing work in several states. I do not have a comprehensive list of all of the consulting firms since, really the passage of the ACA in 2010 that did those analyses. I believe the data source that is referenced on slide 14 did come from an Associated Press file that we accessed years and years ago that was a good kind of timestamp on some of those projections. But Senator James, happy to follow up with you on at least maybe my team has some better information and Medicaid has some better information on some of the most prevalent consultants for those projections. Number two, the reasons why we shouldn't as a state do Medicaid expansion. I'll kind of avoid the policymaking decision comments on that since that's not our role. But I think the issue that we've tried to lay out in the report is really, operational and financial. So it does take resources to expand Medicaid. There is a 10% state match that's required, with the exception of any incentives or any changes that Congress would make to that match percentage. So there's certainly exposure on the financial side for the state. In addition to that, I think on the lists of, cons to Medicaid expansion, and again, to try to avoid the value call, but I think it's important. It really is providing more insurance through the public sector. I mean, that goes without saying here that any expansion of Medicaid would do that, and that's not a position that the Department of Health has. We will operate any program that's authorized for us to operate and do it in the best way, in the cheapest way, in the most effective way that we can. I would say, Senator James, that over the years, Medicaid expansion is kind of a pejorative term now because it's been so heavily discussed with this particular, non-disabled adult option. But Medicaid has been expanded in Wyoming, many times over when you look at the additional programs that the state has elected to operate, whether that's for folks with developmental disabilities or elderly individuals through the long-term care waiver or other types of optional services that we have added on to the program. So that would be my response to question number 2. And Senator James, in terms of question number 3, let me get back to you on that. We have, many different case managers that we reimburse in the Medicaid program, especially in our home and community-based waivers. So our developmental disability waivers and our long-term care waivers. But I'll get with Terry and her team to get more of a comprehensive listing of just how many we have and what that utilization looks like.
Okay, and I think Senator, we're going to pause now and go back to Senator James for a follow-up question. Tell me when you're ready.
Thank you, Mr. Chairman. I see that Ms. Green is on the panelist. Maybe she might be able to answer that question. Thank you.
Mr. Chairman, Terry Green, State Medicaid Agent. In regard to the question of how many case managers we have, I'm unmuted. Okay, can you hear me? Thank you, Mr. Chairman. Senator James, in regard to the question of case managers, there's numerous case managers in the Medicaid program. We are certainly happy to identify each and every one of those and what their functions are. We have health case managers, we have disease case managers, we have waiver case managers. So I'm unsure if there's a specific type of case manager we're looking for, but we're happy to provide those numbers.
I think he's good. Okay. Your hand is up again, Senator James, and perhaps Ms. Green can email you and you can get that conversation going. Do you have a follow-up? I'm going to pause. Okay.
I'm just asking for inpatient case managers.
Mr. Chairman, Senator James, we don't currently have any inpatient case managers. I'm not sure what that would look like we have health management case managers that could likely assist a client that was in the hospital upon their discharge. That would be the closest thing we have at the current time that would represent any kind of inpatient case manager.
Okay, very good. Thank you. How about Senator Pappas? If you have any questions, we'll pause. Okay. Okay, very good. Okay. I think
Why don't we go ahead and take legislative testimony?
that's what
and
I was
then-
going to move to.
Yeah.
We've pretty much exhausted, I think, our questions. Although you will still remain here as for further questions as we work through this issue. Really appreciate your work traveling up here. Looks like you missed the snow back in Cheyenne. And appreciate all the good information, good work. Okay, members, here's kind of our road forward here. It's 11:20. I have three. First of all, so our format will be if there's any other members of the executive branch that are here, like to testify, and any other elected legislators. And I've seen three here.
Therefore,
Okay, so we'll go with, I'd like to go, so here's what we're looking at. It's 11:20. Got four legislators to speak. And so I'd like to keep this thing under 10 minutes each. And then we're going to go to lunch and we're going to come back and we're going to take the first hour, those folks who are signed up against Medicaid expansion. Going to find out how many there are, if there's 5 or 10 or 50. And we're going to divide that time, do an hour against, do an hour for, and we're going to wrap that up then by 3 o'clock, this issue. And it'll be close to our itinerary, and then we'll move on to the next. Okay, so that's the plan moving forward. So with that, Senator Bouchard, I see you here first. Why don't you come on up if you'd like to visit with the committee about this issue? And then who's going to be next? Are there other members of the legislature? I'm looking out there. I don't see any. Oh, Representative Wharf, are you going to speak to this issue? You want to speak? So you'll be next. That's all I see right now.
There, Mr. Chairman.
Are they in the,
Two more in the overflow. I'll get them at the appropriate time.
okay, we have members in the overflow room down the hall. Okay, very good. Hey, Senator Bouchard, welcome to the committee.
Thank you, Mr. Chairman. I just want to talk about a couple of things that were from the health standpoint. Some physicians don't currently accept Medicaid patients, and others limit the amount they do accept. And it's because the reimbursements are so low. And it's a profit model, by Mr. Chairman. I think we know that doctors spend an incredible amount of money to be a doctor. And, we could run them out of this state because there are markets that are much larger that they could operate in and have that model that they desire to keep so much in there to make sure there's a profit in their business model. Moving to single payer, I got to tell you what's happening, Mr. Chairman, in this state right now is people are getting their entitlement checks and they're not going to work. I mean, if you've been in town, you'll notice restaurants aren't even open right now because of that. They have tight hours. I've talked to several business owners. They can't even believe that this small stimulus check in comparison to where the big picture is has caused this problem. I think that more entitlements will create more of that problem in our government. What's really something that's not being looked at in here, when you go and tour some of the facilities that we have supplemented the brick and mortar part of it, with government funding, there's a model built in, a number is built in there to how many beds that they can put in with Medicaid because of the business model is bad. It's going to start sinking. And so I think what's happening is the consequences are if people move to Wyoming to get the benefits because for whatever reason they choose to move here, we're going to create another problem where even the brick and mortar is not going to be able to keep up with it. And we have a piggyback problem on top of an expansion. So if that makes sense, you'd have to expand the brick and mortar to actually compensate. And some of these are hospitals that I visited, one's in Buffalo with a nursing home. And they are very strict on how those ratios of what they do because of the losses and how much they're subsidized already at the state level. So that's the problem. But, most of you have talked about an Article 5 convention, and some even voted for it. And we're always getting emails. Everybody knows very well that we're getting emails saying that we need to do an Article 5 convention so we can stop the federal government from out of control spending. But the problem is, it's not so much all on that end, because the 1992 case, landmark case with Sandra Day O'Connor as justice, said that the federal government can't force the states to do anything, but they can bribe them. And I think that's what we're doing here. We're basically saying, and I apologize, but I mean, this is the image of what we have here. We have the carrot that's being dangled here. And it's the state legislature that either takes the carrot and expands that government spending, and they're printing money. We're going to run out. We're going to run out of space, but we're going to send to our grandkids, and they're going to pay this. They're going to pay for this. And by the way, you talked a little bit about what's happening with what's going to happen here is you've got that Unaffordable Health Care Act, which is severely taxed because instead of having a pool of workers, they have diluted it with a pool of people who need almost free insurance. And so you've got people that are paying crazy amounts of money to have care, even if their need is low. So younger people that make good money have to pay more just because they are there. So that's a shift in cost. And now what happens is, I hear what they're saying. They're saying that, oh, we're going to pull some of those people out of the ACH. I'm just not sold on that. I think what we're doing is we're going to move that whole cost over. And as more people drop off, you're going to have people that work, just like we're seeing right now. Entitlements are causing people to drop off of working. How many people will drop off of the so-called Affordable Health Care Act? How many people will fall off of there and drop into a full pay system and create an imbalance? And I think that's exactly what they wanted to do when they passed Obamacare. It was to make this structure go to a single payer. I mean, and talking about not how we will be able to drop off of this system. Who's going to reverse entitlements once we hand them out? So I think that we should really talk about what we're doing here. We're taking money that's been printed in DC, and we're taking that carrot, and we're going to expand another federal program in Wyoming that we will never see go away. And then the brick and mortar that we're going to have to pay to make sure that those hospital beds on long-term care, issues like that, where we weren't ready to pull more patients into our state. But if we build it, they will come. And that's why I'm saying that we should not move this forward. So thank you, Mr. Chairman.
Any questions, Senator? Go ahead, Mr. Chairman.
Thank you. I'm not sure, Senator, that you were in the room when the Department of Health was asked about whether this is single payer or not, but I think the answer was no. And the second point, I hear you talking about physicians not wanting to treat Medicaid patients. But in the emails I've received a lot of emails from physicians that have asked me to expand Medicaid. I look around the committee, has anyone received any emails from physicians asking us not to expand Medicaid? How many? Couple. I've received dozens from healthcare workers saying expand it. So I think you got to put all these things in a little bit of perspective. What do you think about that?
Senator?
Mr. Chairman, thank you. And Co-Chair, thank you for the question. Look, when we ask people who work in a system, who get paid by a system, I don't doubt there are people that want it in the system because it brings money in. But when we look at the free market and what we're doing to it, how we're going to tear it down, I don't see how it's an option. The option of a market, is much better in how profits come in. We're a capitalist system. We are talking about an entitlement system. And I'm not saying this any different from, I don't have healthcare insurance now because of what we've done to it. I heard some testimony a while ago how we were making a big deal about we have two providers. We used to have an open market. We could go to blocks of insurance, pools of insurance that we desired to, that we chose to. This will end up as a single payer system because as doctors fall out, as they decide they can't have a profit model, why would they do it? They could make more money being plumbers. And that's not a joke. That is go look at what a plumber charges. So that's just my view. I think that's the view of the American public. They're tired of look, when I talked about the constitutional provisions, show me in the US Constitution where Congress should even be dealing with healthcare. It's not there. And that's why that Sandra Day O'Connor case is so important because they know it's not there either. But they can bribe us with this money. This money is to stop free enterprise and to make healthcare fit into the model of the Affordable Health Care Act. It's there. They purposely they cut Medicaid spending originally in the bill, and then they put this as a stage 2. So I just don't see a system it's gonna break. If there's nothing free in life. And that's my question to the committee. Where is something free? Is there free things? Doesn't somebody have to pay for it?
Senator, I think, first of all, you got to think who we're talking about. You're talking from 0 to 138%. It's not like these folks are out shopping around for healthcare, But I think we recognize in the United States there are market failures. A good economist here knows that. You drove up here on a government road. We understand all that. But I think going back to this expansion of Medicaid, we've expanded Medicaid. I don't think anybody on this panel has ever voted. All I've seen is support for the developmental disabled. That's an expansion in Wyoming. I think you voted last session for expansion of Medicaid for school-based services. I don't know what that Senate file was. It 70. I looked on the digest, you were an aye to expand Medicaid for school-based services. Now we're talking about expanding Medicaid for basically women under 45 years of age who are 0 to 138%. That's what we're talking about. And I get all that. And I don't know if in Article 5, we go round and round. These debates go on. They've been going on for 1,000 years, These poor people are deserving, but these poor people aren't. And we will have to decide what group is deserving of these benefits. And I get it. It's not easy, and all those things you said are part of it. But all of us are not totally pure either. There's some things that, government does provide us. that because we aren't getting together now and building each other's houses and building each other's roads. That's in a different era of America. And this federal overreach, no doubt about it. I mean, we live it. We're owned by the federal government. The state's 2/3 federal government, minerals, half the surface. So we got to work, man. We got to keep working at it. But I don't want to get into this, because none of us are pure on that thing. We're going to probably all draw Social Security, Lord willing, someday. And I don't think any of us are going to turn it down. And I know we paid into it, but we're going to get a lot more out of it. And I just think it's, so all of us have contradictions. And so we're just trying to find the right thing to do for these 25,000 poor people, mainly women. I don't know if this is the right answer. I don't. But we're going to continue looking at it and studying it. So thank you. And I think I'm going to try to give you about 10 minutes. You are over, but if you could wrap it up, give you the final word, that'd be great. Thank you.
Mr. Chairman, I don't think it was fair to use something that was a paperwork thing that people were eligible, but they couldn't get it through the school. That's not quite the same as this type of expansion. Two, you were there when we heard Mr. Chairman last time. There was someone who said that they had 4 children under Medicaid, and they said they didn't need it now because they got through whatever problems they had, but yet they were still there testifying. And that's what we do here. Once we expand these things into, let's just do more of it. It seems like people can't get off of it. Instead of getting a hand up, it turns into a lifetime. And that is historically the case. These states around us, they have hospital taxes. They're increasing things because it doesn't work. The reimbursement does not pay the actual cost. And so now we're going to create, again, brick and mortar is a problem, and all the processes behind the scenes. We start increasing those costs, we're going to be on the road to an income tax in the state just to help subsidize this. So that I'll wrap it up, Mr. Chairman. Hey, thank you for letting me speak.
No, thank you. Appreciate you being here. Are there other, Representative Wharf, you're up. Go ahead. Thanks for joining us today.
Most of you know me as Bob Wharf. I'm Representative Wharf from Evanston, Wyoming, and I am glad to be here with you today. I do come here in opposition of Medicaid expansion, and I can tell you my main, I guess, reason and rationale from this is I think back. I think right now when I look at the amount of money the federal government is spending, I'm very concerned about how we just keep and look at all the stimulus packages that have been submitted. I seen a segment, I think it was Saturday morning, and they were talking about having everybody send them all their wants because they got all this money that they want to put in this stimulus package and they want to provide it. And I think this is a similar thing. I think there's been an effort here to make it look as though we're not compassionate if we say we shouldn't be expanding this to everybody and to everything. I think it's a mistake. I just think back. I'm not that old. I'm not 60 yet, but I think back to the things we used to do as a country, and I look at the way we're going. If you don't think there's a hard push for us to become more socialist, you're not paying attention. And I think about all the veterans that went and fought battles in foreign countries so that we didn't have to give up the freedoms and liberties that we have. And I'm terribly concerned that with the actions that we're doing as we become more and more dependent on the government, which that's what I see Medicaid expansion doing. It opens the door to where we're dependent on them to give us health care. I remember when we spoke against ACA, the Affordable Care Act, because we did not want the federal government telling us what to do with our health care decisions and choices. In fact, we passed a law that said the government has no right to interfere with your health choices. And we saw what happened with this pandemic. It didn't matter. The government came in and told us what to do anyway. Now, I do think it's important. I want people to know I'm not heartless. I had absolutely no insurance when my son, who was 8 years old, was diagnosed with medulloblastoma. I mean, my family went through hell for a good 7 years while he was being treated. That's a cancerous brain tumor. Had no insurance, didn't know what I was going to do. I had just left a really good paying job where I had benefits. Went to work for a nonprofit where I was promised benefits and they never delivered. And all of a sudden I find out, here we are, we've moved to a new community and we have no insurance and my boy's facing a life-threatening illness. And I can tell you it was not something I would wish on anybody. But the thing that happened then, I remember going down to Primary Children's Hospital. That's the closest facility for us. And I remember they made the comment, they had the ability to write a lot of our medical bills off, but we had numerous fundraisers that the community put on for my family. My family had been there less than a year, or less than 2 years. But it amazed me that we'd had over a half a dozen fundraisers for on behalf of my family. I had people putting coffee cans out with a picture of my boy saying, please donate. And I can tell you, people rallied around us in our community. We had help from our church. We had help from other churches. And one of my biggest concerns is, and this is something that I see as government tends to expand, the things we used to do as a nation tend to contract and they will evaporate and go away. And I ask, what are we doing? If we continue to expand government, the government's role in our health care, I think it's going to affect the doctors that go into that. I think you're going to see that they're not going to draw the most qualified, the people that really are hungry to be doctors. They're going to find something else because it's not just because money's the incentive, but when it becomes a thankless job, and I hate to say this, but you all know that if it's given to you for free, you're not going to appreciate it as much as if you work for it. I think back to the old adage, give a guy a Cadillac and see how long it's till he's trashed that vehicle. Make him work to be able to buy that Cadillac and he's going to take care of it. And I think we've lost sight of that. That's how our country used to be. When somebody got down, our communities rallied around them and supported them. And that's my biggest concern, is that as we get more and more people that are dependent upon the government for assistance, what you're going to find is sooner or later, this system is going to break. We all have to see that. I mean, if you're not, I don't know how else to present it, but we can't keep giving away trillions of dollars as a nation. And I worry about the consequences. What are the repercussions? What happens when some of these other foreign countries that have invested in our country decide to call those notes due? I mean, I really think we're headed down the wrong road. I don't think we want socialized medicine. I don't think we want one-payer systems. And that's not where we're at, but that's where this leads us. I don't know how you can argue against that. And I can tell you, I know, because I've been following this issue for many years, and I know people have said I used to be against it, but now I'm for it. I think the principle still remains there. And I think that principle is that we were a proud, independent nation. We had people that were proud that we helped each other, we rallied around each other, but we didn't lean on the government for that assistance. And it is there. We need the government to do certain things, but I really think we just keep putting more and more on. And I do know there are alternatives. That's a criticism that I believe is valid. For years we've been saying no to Medicaid expansion, but I don't think we've done enough to look at what alternatives are out there. And I guess I see this, I know it was talked about, this is in the Revenue Committee. I think this isn't necessarily where I think it belongs, but that's where it is. And I do think that we have a duty and obligation to look. I think as a body, that's what we should be doing, is looking at those alternatives and not just saying no. we should be able to deliver something for the people that we all have been elected to serve. And so I get that's where we're at. That's what this revenue committee's been tasked with is assessing Medicaid expansion. But I would just ask you to think about the consequences should this move forward. And I do. I can tell you, I see it as being baited into a trap. And I'm worried that the state goes that direction. Once we're in the trap, we're in the trap. And there's no way to get out of it. And I think it just will lead to the failure of this country, this nation. And I don't want to be the generation that sees it deteriorate to the point. I mean, we just saw what happened with the hack. If you saw it, I mean, it shut down the pipeline. We've got places that don't have fuel. I mean, it's crazy to think that this nation that had all these unlimited resources that we can be brought to our knees. You know, and I just think there's too many things that point back to we're better off to get government out of healthcare. I think things were better. I look back when it was tough, and we were fortunate. We had lots of help, but we got through that trial. And I just think going to this is a mistake. And so with that, Mr. Chairman, I don't want to gobble up all your time, but I do think that's my point that I wanted to make to this committee is we're being told that there's all this money to be had by having the state enroll. I worry about, you know, all the medical people that are coming to this committee and saying, yeah, we need this, we need it. I'm sure they do need it. But I'm thinking that there's better alternatives that don't have the consequences or the risk that Medicaid expansion will bring to the state of Wyoming. Look at the other states that have done it, and it is bad. I tried to get the stuff from Utah. I know just from private conversations, it was forced. Utah was forced through a ballot initiative. They kept voting it down. It was approved. It is their number one issue now with their budget is how are they going to pay for Medicare or Medicaid? And it used to be education. Now, you know, our issues with education in our state, if you can imagine healthcare being more costly than our education, I think that's the direction this will take us. So with that, Mr. Chairman, I'll stand for any questions.
Any questions? Okay, Representative Yin.
Thank you, Mr. Chairman. So Representative Worf, as you know, the bill that we had during the general session had an automatic cutoff if we lost the FMAP percentage. So over the course, based on the Department of Health estimates, we would save government expenditures of $34 million over the biennium that we could use to help support schools, et cetera. And if it goes away, then it goes away. But I think if it does go away, you have 2 years of time where one, you're providing healthcare for that uninsured population for those 2 years, but you can come up with a solution. Do you think that's an appropriate time period to have those 2 years so we can, one, save money in our state government, two, insure people, three, help our local hospitals that have to provide charity care anyways, while we come up with those solutions over 2 years? Because over the course of seven years from 2014 to now, we haven't come up with an alternative. So at the very least, we can at least have Medicaid for these folks for 2 years. You don't think that is helpful for us?
Yes,
Chairman?
Mr. Chairman, and Representative Yin, I think it's dangerous. And I can tell you there's a gentleman that is online. I've contacted him. He's with FGA, one of the guys that I used to work with. And I don't know as much about that, but I can tell you that was one of the things that was said in testimony in the House was that North Carolina expanded. If it's so good, or if it's so dangerous, why would they do that? I'm being told, and I don't have the information with me right here, but I know he's prepared to talk about that. But I can tell you that it is not true that you can get out. Once you enroll, you're enrolled. And he can cite the federal law where it says you can't. And so I just think we need to know that what we're being told is not necessarily accurate. And you look at all the things that have happened, all the predictions that they've made in all the other states, it's never been true. And they always say, well, we didn't get it right, but we're better now. They're still getting it wrong. And I think it's a mistake. And all I can say is I look at the state of Utah and I tried to get that data. It's not available yet. but I just know what I've heard. That I've got a lot of friends, a lot of family still there, and I can tell you it's a Trojan horse, I believe. So that's the best answer I can have. I think there are alternatives, and before we sign on the dotted line, we should be exploring those. And I agree, it's been far too long, and I do think we need to do that. But the only way that's going to happen is if we demand that. And I think we're getting to the stage where we have to do something. Our healthcare costs are out of control, but I think continuing to encourage federal government to be enrolled or involved in our healthcare is not the solution.
Okay, thank you. Appreciate you joining us today.
You bet. Thank you.
I think we have one more legislator, Representative Larson, in the back of the room. And
Can I talk to you privately for a second?
sure. Sorry. Okay, Representative Larson.
Thank you, Mr.
Morning.
Mr. Chairman. Mr. Chairman, my name's Lloyd Larson. I live in Lander and serve in the House of Representatives, House District 54. Members of the committee, I just really applaud the work that you're in the conversation that you're having here today. And I think it's really important that we come back and ask the question, when we talk about Medicaid expansion, who is it that we're serving? Are we going to serve this vast population from one end of the state to the other? And the answer to that's no. We have a population when that by really some decisions, court decisions and political decisions really find themselves in a position that getting any type of health care is very difficult. So when the courts ruled that the Affordable Care Act was legal, we moved on. We have our exchanges, and this helps people that are the 100% of poverty level through the exchange get some insurance. Then we ruled that states are not, you can't force the states to expand Medicaid. And so then we have this population here that's 100% of poverty down. They make too little money to get any help. Seems kind of wonky. They don't make enough money to get any, they can't get help. And frankly, their income doesn't allow them. So they can't get insurance and they can't afford health care. And so we've looked at this thing now since 2013, my first year here. And we voted no. We was concerned about the requirements to, if we expand, we can't get out of it. I would answer that, Mr. Chairman, just looking at this last session. When we looked at our economic conditions of the state and we come in and we asked the governor asked the departments to make cuts, look where the Department of Health made cuts. We made reductions in all our Medicaid agencies. We made cuts to mental health. We made cuts to adults receiving dental and vision, to senior citizen center. So I'm kind of past that excuse of saying we wouldn't have the courage or the wherewithal to back out of that if we needed to. I think we proved that this last session. But so then we said, well, why don't we just get more insurance companies to come into the state? Well, there's two answers there. These people don't qualify for insurance, being the biggest one. And secondly, talking about a free market system, if the insurance companies thought there was a market here to really service, they would be here. And they're not. And so the free market is serving, and we still have this population without insurance. Okay. I think we sometimes consider that perhaps the people that would be most benefit would be the most down and out. And I agree that that's true, but that's not all. I'll give you an example. When my son was in law school, and one night he calls and he says, tells me that his wife's in the emergency room, has appendicitis, going to have insurance. She's 23 years old, would qualify to be under the Affordable Care Act to be covered through her parents' insurance, if they had any. Okay, they don't. Can't fit under ours because she's not our daughter. So there's $26,000 while they're in school, dirt poor. And how are they going to? Does he drop out of law school to pay this bill? Does the hospital then just pay for it as uncompensated care? You know, fortunately, we had the means and wherewithal that we could take care of that. But that is not an unusual situation either. So it's not just the destitute. I think there's a broad array of people of the state that we could help. But for 10 years now, we've come back, and each year we says, what are we going to do? How are we going to address it? And each year we come back, and we, at the end of the session, we don't have anything that we haven't moved the dial. Okay. And we've been worried about getting in bed with the federal government. We've been worried about doing a number of things, but to protect the integrity of whatever it is we're doing, we still leave this population without a means to get health care, and the drain that it is on our health care system, which is a bigger question. I think if you, so I think, Mr. Chairman, in my mind, as a colleague of yours, I think that we come down to two things that I think are important. And that is, what do we do for these folks that really have no option through services? And we can say, but can't we come together as a community? Well, I think we do that, but I think it's also reasonable to understand that it's just not going to happen. Our churches aren't going to come in and fully take care of somebody that has a life-threatening disease. They'll help, they'll do whatever. Yeah, you know, I have to tell you, I'm a little hesitant to help a lot of people now because of the fear of some sort of litigation. If I do something wrong and there's something that goes south in their health care, it makes me nervous. So how do we help this population get insurance? And then what's the cost to the state? I think we have to put this ARP money aside. We know that it would equate 8/4, 2%. It comes in about $54 million. It would cover the first two bienniums, first 4 years, but then it goes away. I think if you look long term, we have to say, how then do we cover the cost of expanding Medicaid? I think the department says $10 million a year, $20 million a biennium, but that I think, you know, I won't be conservative. Let's say it's $30 million a biennium with the growth of that. Then how does the state take care of that? And what options do we have? I think that, Mr. Chairman, you brought up a great point. If we can change the FMAP rate, 5% on the FMAP is $25 million a year. If we could change that to what their surrounding states are, more than covers our expansion. I think that, and then I think the impact that it has on our hospitals, our ambulance services, and all of those is enormous. But I think we then cover the costs of what that of the general fund dollars that I at least that's been my sense, has been a big concern of ours, of how do we cover the costs. And so we have to have a bill. We just do. And the reason I say that is if we say, well, if the feds will, okay, let's just pretend, let's just have these two guys here, the director, go talk to CMS and say, how about, and throw out this chip. They aren't going to do squat until we have a bill. We've worked enough with Medicaid, CMS to understand that, and you know, if it's an 1115 waiver, you have to have the waiver in place, passed by the legislature before they can actually respond on it. So if we want to know what options really this administration will do in order to incentivize or help Wyoming expand Medicaid, we have to have a bill in place. And I think that I think Representative Breaker brought it up. Why do we need to do that during the special session? And I think that is to outline what the expectations we have in the bill, so that then the Department of Health could go ahead and start that negotiation. So in the event, in the next session, the budget session, if we needed to tweak or do anything, we've got the time to do it. And so I would really hope that this committee would put into consideration having a bill that would give the Department of Health the authority to negotiate with CMS, but more and equally as important then is to put the criteria in there that you feel is important to the state. If it's increasing the FMAP, make sure that it's in there. If you feel that it can't go below 90%, put it in there. If you feel that if it goes below 90%, that we're out of here, make sure that that's in there so that it gives these guys the directions they need to negotiate with the Fed. And then if they come back, if our federal partners come back and say, ain't gonna happen, we're no different than we are right now. Okay? But we can't have that discussion until we have a bill. And so I'm not on this committee. I work a lot with the department in my other committee, and my view on Medicaid expansion has changed. This is the first year that I voted on it, and I hope I've expressed my rationale as to why I voted on it, because we haven't done anything. We haven't moved the dial to help this population. They're stuck. Do we have an obligation to do something? I think we do. I absolutely think we could do. If we had 25,000 kids not getting an education, do you think we'd be jumping on that like a hot potato? If we had 25,000 veterans that couldn't get health care, would we jump on that? Absolutely. But we got the same thing, and we have a responsibility, I think, to address it, and we at least need to have this bill in place for us to consider so that we can at least have the discussion to move that forward is my opinion. And that's, Mr. Chairman, I appreciate, as a colleague, I was just wanting to make that plea to this committee to try and make sure that we have the option to continue this discussion forward.
Okay, very good. Any questions? Representative Larson, Representative Gray, go ahead.
Thank you, Mr. Chairman. Representative Larson. So just trying to dig down on some of the specifics on what the direction you want to go. You know, I'm opposed to this across the board, but I do want to understand your distinction there, because there's been like two approaches in these bills. There's been sort of these authorizing bills that allows the DOH to negotiate. And usually it says that then they have to come back and get approval from the legislature. But sometimes there's been drafts that have appeared to give the governor authority to expand regardless of how that negotiation plays out. And then there was like a bill that, once amended out of revenue, was the one before the legislature last session that appeared to just say that expansion, just expand. So I'm trying to understand exactly what you're asking for, because it appears to be a little different from the direction that has been gone in the past. Thank you.
Go ahead, Representative Larson, and I think it's a great question, and I think, and that whatever that House bill was that passed, it had the 90-10, and I think it was a 55-45 FMAP. I think were the two qualifiers, but go ahead. I wrote those notes down too on what, and I guess I want to expand on Representative Gray's question. So the bill, then we can write it in multiple different ways, but we set out the negotiation parameters for the executive branch in the bill, if that's what we want.
So, Mr. Chairman, in Representative Gray, I agree with you. I think, and I'm not saying that I'm right. I'm giving my opinion, and I'll give the rationale behind that is when in 2013, when that first come out, it was that the governor of the state could negotiate with the federal government to expand Medicaid. We put a condition in there that says, no, it has to go through the legislature. And so we says the governor can't negotiate, which is these guys, the executive branch can't negotiate without legislative approval. So that brings us, in other states, the governor just went and negotiated. But here we are, and that's us. I liken this a little bit to the exercise we had this last session with our education bill, where we said we kind of had two options: cut $100 million, and then we tell the superintendent of public instruction to go do that. She goes and does it. She said she makes those cuts where she feels is reasonable to do it. Then the school districts get upset. They say that wasn't the legislative intent. They didn't want you to cut this, and Then we get tangled up in lawsuits because we didn't give clear direction. Then we come back in the House, we had this bill where we went in and we went into the model and we says, these are the parameters that we would reduce funding for education. And so we made it very clear. Well, I think when the executive branch goes to negotiate with CMS, I think if they don't have some direction, they negotiate what they feel is in the best interest, just like we did in education, and say, this is what we think we want to have, bring it back to legislature. We says, are you guys crazy? What do you know? Where'd you get those mushrooms? We don't want that. And so we get tangled up in that. But if we give them the guidelines ahead of time on what we expect legislatively that we think is palatable for our costs and for what we want to do, then they know how to negotiate. So that's my logic in doing that.
Thank you, Mr. Chairman. And I do want to be clear. I am opposed to cross the board, but I want to understand what you're asking for, because do you want a second approval through the legislature? So do you want a two-step process where the legislature is authorizing and then approving, or do you want them bifurcated? Or do you want it all in one? That's my I'm just trying to understand what you're saying.
So, Mr. Chairman, so I think it could be, I would prefer it in one. Okay. But as we see in a variety of things, sometimes it takes two bites to eat the apple. But if we could lay out the conditions that we feel are appropriate, that they could go to, and that's just use the FMAP. And they go to negotiate the FMAP, and I fully expect that this administration would come back and say, we can't do that. That's a congressional action. My response would be back, but you have the House and the Senate. If this is important, work on it, and we'll get that done. And so let's just say that all the stars align and they come back. We got an FMAP approval and we got the 90% and it can't go yada, yada, yada. They've met the conditions of our bill. There it is. But what if? What if they come back and said that they'll agree to the FMAP, to this, and there's one other condition, and that condition isn't in the legislature? Then we would probably have to take a second bite of the apple in this next session to make it fit into the bill.
Okay. And Representative Larson, here's the things I've written down, kind of listening, and I'd like if you know, whether anybody agrees with me or not, but if there's some other ideas, if you think this is crazy train, let me know. The first thing I wrote is that there would be no appropriation to expand Medicaid. And after this 8-quarter incentive period, after it would be paid through offsets. That's one part. The other part would be that the 1985 law that Representative Yin talked about, at 35-6-117, passed 1985, you know, prohibiting public funds for elective abortions. That's got to be part of it. The 90-10 has to stay part of it. Can't go lower than that. And then I put this number, I just looked at that bill we passed was 55-45, but I put it at the 5-state average FMAP, our 5 bordering states, which is 60. And I think it's realistic when Montana's 70, Idaho's nearly 70, Utah, and so on. I don't think that's unrealistic. And that's over 50 million a year, state general fund dollars. And really that we're in that part. I talked about the weighted average from 230,000 household from Teton County. So is that crazy train, or are there other stuff that should be in there, or is that too much? What's your thoughts? I mean, we're not to that point yet. We got a lot of testimony, but these are things I'm thinking about.
I think about the rudimentary things that need to be in there, and those are the things that you mentioned that I think are rudimentary or important. I think I would exercise some caution or suggest exercising some caution. And that's that we don't become, that you don't try to put things in there that burden down the operations of administration. Okay. So, an example of that, I think, could possibly, you look at Healthy Indiana, you look at Arkansas, where they bought everybody an insurance policy. You look at Michigan. Michigan kind of done an interesting thing where they got everybody a debit card, and then there was some interesting malice that took place. That all of a sudden became a currency. They were swapping these debit cards. They were doing all sorts of things. It becomes a burden in the administration of the program. So I think as you consider things that are palatable to the legislature, I think it's important to look, as you listen to Mrs. Green and you listen to these people in healthcare financing, our administrative costs are low. And they're low because we try and do it simple. And so try not to put things in the bill that would add to their burden. This last year in the legislative session, you'll recall that we moved the Child's Health Insurance Plan, the CHIPS plan, which was being administered by a private insurer back and is now administered by the Department of Health. And one of the reasons is that the administrative costs were significantly less in the Department of Health, and admittedly so by the private provider than they could provide, and they could not provide at that risk. And so I think keep it simple. It is for administrative purposes is the only other thing I would suggest.
Right. Any other questions? Yeah, before we go there, any other questions here? Representative Jennings.
Thank you, Mr. Chairman. Thanks for being here, Representative. You brought something up that's it's troubled me in my 7 years. And so I wanted to get your take on this.
Is that just my name or?
Beyond that. So you mentioned that we haven't done anything. You haven't seen anything occur. And in my 7 years, I've seen that we passed a law allowing doctors to put some kind of health care in place preemptively. And I was actually disappointed that the health department didn't give us alternatives. And that's one of those things that really bugs me in the legislature is I don't mind making the hard decisions. I mean, probably everybody in the room and half the state knows how I'm going to vote on this. But I'd like to see alternatives. I'd like to know, well, when we had an opportunity and we passed a law that allowed doctors to set up, and my understanding is that that's growing, that there's a number of doctors that have taken that on, and a family pays $125 and whatever, and they get preventative care. And so I'd like to know how programs, we passed legislation aimed at this very thing. And there's things out there like MediShare. Well, how does that impact? But it seems like that every single time we come back to a governmental idea, this is the only thing that comes to the table, and it's the only thing we hear testimony on. This is the only solution that we have ahead. We have to do this. In fact, I think those are your words. We have to do this. We have to have this bill. And so I agree that the legislature has not looked at alternatives nearly as far. But when we passed some of that legislation, I mean, maybe it's shame on you and I. Maybe we didn't come up with more alternatives. But does that concern you in this, that we almost always come back to one thing? And you've been there longer than me. It looks to me like we should have looked at more alternatives. But is it because we just get the door slammed on those alternatives? Or is it because we didn't do our due diligence and bring enough and then maybe refine the ideas that did come forward? Maybe there was a way to help on this idea of doctors doing preventative care. Maybe we could have saved more money. So I'd like you to expound a little bit. I do take a little bit of deference that we actually have done a couple of things.
Mr. Chairman, so I think that there's a couple of things, Representative Jennings, that you mentioned. The primary care, the change we made in primary care where a physician, where a family could come and just pay a monthly or a fee, and then the primary doctor would do that. I think that was last year that we had Chairman Harvey in our midst, and she was chairing Labor and Health, that we'd done that. And that's working fine. And I think it's a great idea and it is expanding. But I still, and does it reach into this population that we have right now? Possibly, but I probably not. And so I would stand corrected that it's reaching into that we are making some changes, but I don't think it's reaching the numbers that we would like to see. We also done another thing that you didn't reflect on, but what's brought up, we have patient-centered medical homes, which was an idea to keep track of these high utilizers that are between the ages of 21 and 65, but maybe have conditions, and we provide a fee per month to make sure that they're coming in, staying on their medications, and keep them out of an emergency room. I think that that's working. I think that that's working successfully too. I don't know, again, I think that that's chipping away at the apple. Medishare, it's what me and my wife have. I checked on that because I had another family member that I thought would qualify, and it was too expensive, and it was not a whole lot different than health insurance costs. I know it's not much cheaper for me and my wife than if we were on one of the other insurance policies. I think that we have been looking. I think that we need to continue to look. But then my question back to the committee, is this also not an option that we should be looking at? And I think we are saying, yeah, and we are looking at that. I say, Representative Jennings, I'm saying that I think it's important is we consider, to your point, that it's important that we consider our options, is why I say it's important that we need the bill. Because if we're fully going to vet out the options that are available to us in the expansion Medicaid, we have to have a bill to do it. Mr. Chairman.
Thank you, Mr. Chair. And I want to go back on this, Representative Larson, because Senator Case just sent the engrossed bill 162. And I'm just not understanding the distinction, because the way it's being presented is that you're presenting it as that, well, it's providing these options, but the way it's worded is that the negotiation occurs and then the Medicaid expansion happens. And yeah, there's conditions in subsection B, but it's happening. It says they shall negotiate and then it will happen. It culminates in it happening. So, I'm just trying to understand if there's really any distinction, because I don't think there is. And I think you tend to maybe think there is, and I don't think there is. So,
Mr. Chairman, in fairness to that, Representative Gray, I'm not even looking at the bill. Okay, I'm going under the premise that you are going to craft a bill, and so I don't have a draft to refer to or to make that distinction. I am merely making a suggestion to you as colleagues in the committee that's going to consider this, that as you craft a bill, that you would consider some of these options. And so I thank you, because I was trying to figure out where we were getting tangled up, but it appears to me that you're referring to a bill, and I'm not. I haven't even read it. So is my 10 minutes up?
As you read your 10 minutes is up. Yeah, no, as you read that bill, that paragraph B says it will not be administered if the 90-10 changes or the 55-45. So that's where the parameters it's written in. Now, I think Representative James is online and has a question for Representative Larson. And then when we're done with that, we're going to break for lunch. We're a little behind. I think we got a little long-winded with our legislative friends, and next time that isn't going to happen. I'm going to tell you, I'm going to give you about 3 minutes there, Mr. Wharf and Mr. Larson, but it's all good. Okay, we have to be quiet, and then we're going to give them a thumbs up when I get a thumbs up. Mute your mics.
Thank you, Mr. Chairman. So my first question is, does Representative Larson happen to know the exact location in federal statutes where it says that the states have the ability to get out of Medicaid expansion if they choose to? And then my second question is, since around like, I'd say May of 2016, what has been the waste, fraud, and abuse levels of the Medicaid within Wyoming? And what are the plans to combat the waste, fraud, and abuse if we were to expand Medicaid expansion? Thank you.
Thank you, Mr. Chairman. And Mr. Chairman, before I answer, I apologize. I had not planned on taking this much time. So Senator James, the simple answer to your first question on the federal, where it's at in federal law, I can't quote that. I do know that we have asked that question of the Department of Health, and I trust what they have provided for us here today 100%. It's they don't come up here and tease us with artificial facts. When Mr. Johansson tells me that they've looked into this and that they know that we can pull it out, I will go to the bank on that, and I'm sure that he'll provide us with the information. But myself, I'm lucky to know my social security number, let alone any of those other things. Fraud and abuse, I don't know if you're aware, but within the healthcare financing division of the Department of Health, we have a fraud division in Medicaid. And as recent as 2 or 3 years ago, turned over in one part of the state a pretty significant fraud, Medicaid fraud provider that is now serving time in prison, and that's an ongoing thing. I think that fortunately for us, is we have this fraud division in place, and I think that they do a pretty heavy lift in trying to make sure that those federal dollars, as well as our state general fund dollars, aren't being maliciously used. So I think that's in place.
Okay, thank you. And with that, I think we're going to shut this down for lunch.
Mr. Chairman?
12:21.
Mr.
Let's come
Chairman.
back here right at, would like to get started by 1:30.
Mr. Chairman.
And then we'll kind of take roll of where we're at as far as number of people who want to speak. I'm talking about only in-state Wyoming people today. And we're going to go from there. And we'll take those against and those for. So we are on recess now, and we will begin promptly at 1:30. Thank you all.